Welcome, everybody. It's so happy to see you here at the Insurance Untangled event. Welcome to spring. I'm very, very happy to say that. Got a note from a friend last night that said it was spring, and I was just delighted. So that's terrific. Naren Arulraja is going to give us some wonderful welcoming comments and let us know what we're in for today. Hi, Naren.
Hi, Shelley. Thank you for emceeing this event. Both Ben and I are, really happy with the team and what they have done to put this all together. So let me just kick it off by sharing my slide, kind of going over the agenda, and then, we can go from there. Give me 1 second. Can everyone see my slide? Perfect. So hello, everyone. I'm Naren. I'm one of the founders, along with Ben Tuane, Naren Arulraja of the Insurance Untangled community. We have a podcast, we have a website, insuranceuntangleded.com, and we do these quarterly events. And we are really excited about today's event. And the topic today is strategies for sustainable growth in 2025. So we try to pick a theme around our quarterly events. And today I'll go through the agenda a little bit, but we're going to have some exciting content. I've been working with dentists for 18 years now. So there's one thing I know is there's always challenges, right? We think everything is, going well, but then all of a sudden something happens. Of course, we all went through COVID, we all go through the economic cycles and shifting marketplace, the competition, the insurance companies and what they're doing, and consumers and how they are behaving. So this is a really good time to kind of talk about, what works, what doesn't, what are the few things we can focus on to sustain growth and continue a strong 2025. If you have had a great Q1, then obviously you're going to build on it. If you are struggling, again, this would be a great, almost like the CPR, like giving the CPR to get that person back alive again. So it'll really help you kind of, get out of whatever slump you're in. So I'm really looking forward to it. So I'll go through the agenda real quick and then give it back to Shelley, who's our MC today. We have an insurance panel happening. That's what's going to be happening in a few minutes. Shelley will, moderate it. Tessina, Leslie, and Janelle, they are amazing experts when it comes to insurance and everything to do with insurance. Of course, I'll let Shelley and Tessina, Leslie, and Janelle talk about their backgrounds and how they help practice owners. Then Ben, who's a genius, who knows so much about negotiations and working with insurance companies, going to do an awesome presentation. So I can't wait to hear that. And then once Ben is done, I'll do a presentation. I'm going to be focusing on the 4 biggest marketing mistakes and how to avoid them. I really think the difference between people who continue to have the best year every year is they learn from their past. It's not just working harder, because I've been doing this for 18 years, and I'll be lying to you if I say I'm working 18 times harder or a lot more harder today than I did 18 years ago. So the goal is, how do you continue to grow? And the best way to do that is to avoid mistakes, avoid the traps, the pitfalls, the going around in circles. So you are doing the smart thing. So I'm going to share my experience on that. And then, of course, we have a quick break just to kind of catch up, get a drink. And then we'll finish with our business panel. And the business panel will be led by, again, hosted by Shelley. And we have Rebecca, Leah, and Carla. And again, we'll go through their backgrounds and what they do when it comes to helping practice owners on the business side of dentistry. So that's the agenda for today. You will get 3 hours of CE. Of course, we follow the protocol. So you have to be here the full time. And, there's going to be other things you have to do to get that CE. So be here, enjoy the content, and obviously get that amazing CE that hopefully, would also benefit you. That's it from me. So welcome, everyone. And Ben will be doing the closing remarks. And we'll try to keep everybody on time. And that's Shelley's role as well. So thank you, Shelley. Really appreciate you and the team for putting it all together and, making it all work. It's a lot of work. So I know it sounds simple, but thank you for everyone for, everything you guys have done so far. Shelley, take it.
Thank you, Naren. Awesome. Thank you, Naren. Very excited to do this. I had a really, really good time the last time we did this, and I'm very excited to be here again today. Welcome, everybody. We're going to start, as Naren pointed out, with the insurance panel. I'm very, very excited to have Leslie, Janelle, and Tessina with me. And let's start out with some introductions. And I'm not going to sit here and read stuff out about you guys when you guys would be so much better at telling me what you do, why you're here, all those kinds of fun things, and tell us a little bit about your businesses as well. So let's start with Tessina.
Let me find my mute button.
Yeah, exactly.
Right? I'm like, where is that? Good morning or afternoon for some of you. Yeah, so I have been in dentistry since 2008, 2009. Started just a wee lass in assisting, and never ever intended, actually, nor wanted to do everything that I'm doing now. I just wanted to go, to work and go home and relax and not have stress of running businesses. My father ran several businesses, and his specialty was saving struggling businesses. And so, sadly, to my fault, I actually learned a lot from him. I say sadly, but no, wonderfully. I was able to watch that all throughout my youth, and was able to use that to further my career just as a dental assistant, into dental office manager, into study club manager, into consultant, and my newest thing is the insurance verification services and fee negotiations. So we love it. It's just been a whirlwind, throughout the last, I don't know how many years that's been now. I don't want to age myself too much, but my passion is probably giving power to the offices, taking the power back from the insurance companies and putting it in the hands of the offices themselves so that they can really advocate for their patients.
Thank you so much. That is awesome. I'm so happy to be chatting with you again today, Tessina. Leslie, can you tell us a little bit about yourself and what you do and your business?
Yes, I have been in dentistry since '84 when I started as a co-op in high school. And I worked for pediatrics for 2 years. And then I went into oral surgery in '86. And that is where I found how to bill the medical payers and, because we have trauma cases, fractures, lacerations. And so I was in oral surgery for over 32 years and basically have found my niche is, helping other dental providers get medical benefits, basically, because we're doing in general dental practices more ancillary practice or procedures. We're bringing in oral surgeons, or we're doing complete bony impactions ourselves, or sleep, obstructive sleep apnea. We're treating that. So the need is to really be able to build a medical and dental. And so my business is I do have insurance billing outsourcing where we do that for you. And then a newer product that just started January is Dental Classroom. And that is where we teach you how to do medical billing. It's 12 CEs, it's just online modules, and it comes with a year of coaching. So if you do need to bring medical billing in-house, that is an awesome option for you if you want to do it yourself, or you can outsource it. So my background's been oral and maxillofacial surgery, and I've enjoyed that field for many, many years.
Thank you and welcome. We're so happy to have you chat with today. That's absolutely terrific. I really appreciate the intro. And Janelle, you're there somewhere, I think.
Yes. Hi.
Hi, Janelle. How are you doing?
Good.
Good.
My background is I've been in dentistry since 1998. I was an office manager and a dental assistant, and then became a hygienist in 2003. And I've been a hygienist for 22 years. And I've worked in California, Oregon, Idaho, and now Utah. And I've always stayed up on insurance, just making sure that I know what codes that I should be billing and that I should be doing those certain procedures and making sure that they're accurate. And also as a hygienist, I just make sure that I collect all the information that the doctor needs, that the insurance needs, that the patient needs as a baseline, and that what we have to send to insurance companies. But then also just the preventative part of dentistry is what a hygienist focuses on. So I've done a lot of that, and also advocating for my patients and making sure that they understand what treatment they need, but also making sure that we can help them to have the utilize their insurance as best as possible. So
amazing. Thank you so much. For those of you who don't know me, I'm Shelley Schultz. I work with Equa Marketing, who is the sponsor of these kinds of events, along with Naren and Ben. And I have a really, really good time doing that. I have about 20 years in dentistry, and my background is mostly the EMR, CRM space. Lots of fun stuff there. And very, very, very happy to be in marketing and that side of things as well. So trying to span both of them, more the business side. So insurance is something that I actually really do like talking about codes and things. So let's dive in, shall we, ladies? So our first question is, now what we have here is a lot of questions that we've been asked through the association over time, and we're blending those together, and we're going to try and make sure that we have them. The questions are directed to everybody, but if somebody on our panel has something to put in, please pop in, right? Like, let's make this really educational for everybody here. And we've got such a great wealth of experience here. Let's make sure that everybody gets to share that. To that point, Tessina, we have the first question for you. And it is, why is it important to know your ADA codes for 2025? And where do you get the fees for them?
Yes, thank you. That is such a good question. I often run into offices who are coming to me concerned about billing and coding all of the time, of like how they've been doing work and not billing for it because they didn't know that there was a code for it, or they didn't know how to use it. So it's really, really important that every single year, and we're saying for 25 because this is where we are, but guys, I want this regular yearly practice, is to get your new CDT code book every single year. I have mine right here. I went and grabbed it. So our 2025 CDT code book, you go and grab it. At the very, very back, we have the additions and deletions and revisions. So I also run into offices who are billing deleted codes. And this is going to cause a really big problem with your claims getting paid, because they can't get paid if you're using an old deleted code. So make sure you not just know your new codes, but you take out the ones that are deleted. A lot of times our softwares are very helpful in this and inputting them or taking out what needs to be taken out. But if you for yourself are not aware, or you have those multi-code buttons when you're charting, you're still charting old obsolete codes, or you're missing the new codes because you don't have them filtered in yet. So take a look, glance through it, make sure you're familiar with it. And then for the fees, some of these fees aren't set yet. The market doesn't know yet, but a lot of the procedures are similar to another procedure we've already been doing, so we can base it off of that. Or this is something you guys have been doing, but there hasn't been a code for it. So you've already marked how much you need to get paid for it, or what your overhead is on it. Go through, find out how much it costs you to do that procedure, times it by 2, and then inflate it by 10% more, and then bill that to the insurance company. You want your fees to be a little inflated. You can offer some cash discounting, but we need to put it a little higher on the mark for billing to insurance companies so that they can see that. The insurance companies sometimes don't set the fees or the frequencies or the allowances until we start billing it. So it's really important to hop on these new codes, start billing them right away, and we set the fees.
That is such a like that basic, I'm going to use the word hygiene, but not related to teeth this time. But that basic data hygiene, that is such a great comment to call out in your combo codes and your charting, to not change those. Is, you're right, that is such a big oversight. And if you don't know how, your practice management system people do. So give them a call. That's a really, really good call out there. Leslie, our first question that points over that way is, what emerging trends in medical billing should dental offices watch out for 2025?
Shelley, that's a great question as well, because we're going to be seeing more coverage. July of last year, the Medicare started allowing us to submit electronic dental claims to them. So that tells you, I was at the National Association of Dental Plans meeting this last year, and CMS, which is the Centers for Medicare, and Services, as well as Medicaid, was really giving numbers of how much they would have saved if they would have started covering issues when they started, in the oral cavity. So
right, finally. Yeah,
exactly. Yeah. So one trend is we're going to start seeing more coverage, which means we're going to have an increase in submissions to that. We've already seen the change with like our Medicaid services requiring the ICD-10, the diagnosis code on the procedures. And then June 1st of this year, Medicare Advantage plans, Medicaid, Medicare, of course, have always been doing that, are going to require modifiers. And I'm not sure if all of the clearinghouses are ready to adapt that. I'm sure they're struggling too. So you're going to see, as far as a trend, really needing to know what those modifiers are in order to append those to the claim, getting familiar with the diagnosis code system. And I just see the merge as far as the word trend that you use, Shelley, as far as the merge between medical and dental billing, it's getting closer.
Yeah, it's stunning that people are starting to recognize that preventative medicine helps.
Yes.
Janelle, we're going to swap over and we're going to ask you the first one is, what is the role of a dental hygienist in a dental practice? That sounds like such a straightforward question, but things have been changing and shifting over the years.
Yeah, it has. My role as a hygienist is I do all the preventatives part of it. But I also am the one that in my practices, I see the patient first. And I gather all the information for the dentist to be able to do his exam. And I make sure that I'm very thorough, that I gather health history, any complications that are an issue for further treatment, or a part of their the disease process. Also, medications, what are they causing? Are they causing dry mouth? Do we need to focus on that as far as preventing cavities? And gathering all the x-rays. And I use the intraoral camera a lot. So I do recommend everyone start doing that. So I gather a lot of information, and not only for the dentist to be able to diagnose, but to educate the patient, show them what is in their mouth, what is going on. And then also to be able to submit that to insurance, that is a backup. Like if they can't see a good x-ray, you have an intraoral picture that shows what is going on with that tooth or what's going on with the gums. And then also just a thorough charting, making sure that you have the baseline of your perio chart. And there's also other things that we can look at that some offices are incorporating in their office, as far as like bacterial slides. So they're starting to get cultures, things like that. And there's a code for all of these things, so it's really good to know that you can bill out intraoral pictures, you can bill out oral hygiene instructions, nutritional counseling, tobacco counseling, all these things that you're going to go over with your patient. And I also help the dentist, and it's kind of fun when I'm working with newer dentists. They always say to me, "Oh, I love the co-diagnosing." So I feel like us as hygienists, we need to be right there, helping that dentist diagnose. And even though that is not our job, but we know enough, right? Us going to school, becoming licensed, we know enough to help that dentist make those decisions and help with that. So I feel like we're a big part of it, and also to have our schedule filled and working on routine visits so that we can catch things early, as far as cavities, or if the patient needs a crown or has an infection. If we're catching those things early, that's also helping that patient, but it's also helping the practice to fill the schedule. So
thank you. This isn't on our list of questions, but something that you said, I'd like to pull apart with the three of you a little bit. You talked about tobacco counseling, those kinds of counseling, and putting billing against those. I'm wondering, what of those, can we anticipate those being covered by insurance? And another place that my head goes are those things that we can actually put for the patient, where we're providing a service that should have a charge, but now we're going to give it to them as, perhaps a service from the office. I'm interested to know what the three of you think of those kinds of things and how they're accepted by patients, insurance, et cetera.
As far as what I have seen, Shelley, you're not going to see a lot of reimbursement,
Yeah.
but you are going to see it allowed to be billed to the patient.
Right.
And interestingly enough, I had done just kind of a predetermination with one of the payers on their portals just to get an idea of how much oral hygiene instructions are going to be covered. And of course, with my oral surgery background, what I felt was super interesting is that an oral and maxillofacial surgeon, this was years ago even, was allowed to charge up to $110 for oral hygiene instructions to the patients. And so
Okay.
my thought process on that was, well, as an oral maxillofacial surgeon, if a PPO plan wants to give you a 4% increase across the board, they may
Right.
put it very heavy on oral hygiene instructions because they're never going to go over it. It's too late at this point. We're taking them out, or removing the teeth.
Yeah.
But I thought it was interesting that the allowed amount was so high when I was expecting something more like $25 or,
Right.
something.
Yeah. Yeah.
So to allow the others that work more in that arena take over, I just would have to say that, I don't see coverage, but I will see that we're allowed to charge or bill that patient that amount. So.
Got it. Got it. And Tessa and Janelle, anything to add to that?
Yeah, I concur with what Leslie is saying is you can look at those allowed amounts sometimes from the insurance companies, like she was saying, they can put those really high because it looks like you're getting an increased fee schedule, but they're using it on codes they know you're not going to use. So this goes back to what I've said several times. If we're not billing codes, then there's no coverage for them. So
Right.
if this is something we want to be doing and we want it to be covered by insurance, then we need to be billing for it. We can use their allowed amount. We can set the fee ourselves. So even though the allowed amount may say $100, if it's truly not a covered code, then you can charge whatever you want, which may actually be less than $100, right? That we can just set that fee for ourselves, but start showing it to the insurance companies that we are doing this and this is something that needs to be taken care of. Another question I get from a lot of offices is sometimes they're looking for these little add-ons to increase their fees because they're unhappy with their contracted rate. I don't recommend going that route to try to increase your overall fees, but if you're doing this work and it was done, then we should be billing for it. And that's what we should be doing and showing the insurance companies that needs to be done. The other end of that question that I get is, isn't that just going to use up the patient's maximum? What if that is covered by insurance at $100 and now that patient has used $100 of benefits towards that,
Right.
and we have other services we need to do?
Yeah.
So again,
that's a really good pullout from it, right? Because you would end up with a patient saying, well, wait a second, I would have waived that, right? Yes, that's
yeah, exactly. So take those things into consideration as to what we're billing, what we're not billing, and using, we want those codes to be covered. Right now, it's not covered. If we are billing it, hopefully someday it'll be covered. But then do we want that benefit to take away from the patient's benefits? Or do we want to say, let's not bill this one to insurance. This is how much it costs for you. We went over that extra coaching. There's a fee for that, but we don't want to bill to insurance. We want to be able to utilize your insurance towards these other procedures. So just some things to take into consideration with that. But bottom line, I say, if you're doing it, you should be billing it.
Absolutely. And Janelle's probably got those in those combo codes that we talked about. So hopefully you're hitting one key instead of 17. Okay.
Right.
Let's rope back around and let's start talking PPO. Should I be dropping any plans this year and why? Oh, I can't wait.
Yes, that one for me, sir.
Yeah, it is.
Yes. Ooh, dropping PPO plans. This
Yes,
is such
you
a thing. Yes, you should.
Everybody here can help you.
Everybody, we can guide you through this
Yes.
process. It's not as scary as it seems. What happens is year to year, we're going through and just kind of complaining about the fees, complaining about how does the doctor see an increase. Staff is asking for increases yearly due to cost of living going up. Our costs of supplies and materials are going up. The fee schedules have not been going up. And very few offices are evaluating their plans and selecting which ones to drop each year if they are not a good business relationship for them. So right. I strongly evaluate you should be running reports at the first of every year to see what was your biggest write-off, what was your worst paying insurance last year. Yeah. And you probably can't sustain that this coming year. You went through it last year, you tried it. Did they give you an increase? If they didn't give you an increase, it's time to drop. Can you ask for an increase? Yes, you can. If they don't provide it, should you leave? Yes, you should. And just do one at a time each year as you go through this process. And this is a two-part solution. You can continue to see those patients, offer your own discount, and insurance companies see that those fees are no longer acceptable. And if they want providers, they need to increase their fees. By us not changing anything because we don't want to negatively affect our patients, you're not helping your situation and you're not helping your patients get good quality of care. If you want to help, the best thing to do is to drop those plans that are not a good business relationship. So again, that write-off you're being asked to take is for marketing.
Yep.
They have out-of-network
Call
benefits.
us. Call us. We'll help you with that. You don't need the PPO
Yes,
market. That will
exactly.
market for you. No problem. Yeah,
Exactly.
exactly.
It's a marketing fee, and at a 50% write-off, don't market for me. That's not a good business relationship. That's too much to pay in
Well,
marketing.
and it's ongoing. Like you're not going to
Yes.
like, it's not patient acquisition. So patient acquisition is the money that you're paying to have the patient walk in the door.
Yes.
And then you start realizing revenue on that. Now, if you're constantly paying the PPO for the patient you got 4 years ago, oh boy, that's
not a good business relationship.
No,
that's
it's
not a
good for
good
the patient.
marketing
It's not good for
platform.
you. You can't improve
That's
your
right.
office because you're taking 70 cents on the dollar. It just
Yes.
doesn't work all the way across. And that 70 cents on the dollar is permanent. So the faster you can move away from PPO, maybe you're left with one of the big ones, right? Okay, sure, depending on your demographic, but don't be bogged down by all of them.
Yes.
Leslie, Janelle, would you like to contribute on that? Because it is a huge hot subject. And I fully agree with Tessina that if we don't start changing and dropping the plans and moving away from it and saying, no, this isn't good enough, it will never happen. They won't change because they don't have to.
Yeah, I feel like it's so hard because after you educate your patients and you tell them what's going on and this is the treatment, they first thing is like, well, what will my insurance cover?
Yeah.
Or, I had a patient the other day that had to come in because he had a toothache and we did a full comprehensive exam and he says, well, I'm getting insurance in, and he ends up needing a root canal and a crown and on this one tooth. And he says, well, I'm getting insurance in June. So, and I said, well, are you planning on waiting until June? And he says, yes, I'm going to wait. And I was like, okay. So I just sat there and educated him on his insurance. I was like, you need to look at what your insurance covers. You're going to probably max out with just this one tooth, I'm like, and then you need
it's not the pot of gold at the end of the
I'm like, you still need 3 more fillings and you still need those 6-month cleanings and you still, and so I was trying to educate him on, what is going on. And then today for that appointment that day, he was using his HSA card. And I was like, oh my gosh, like, that's so great that you have that available. But like, look at your insurance, really look at it when you get that, because you're not going to be able to utilize it the way that you think you are. So it's really hard.
I think that patients don't truly understand, and it's our job to educate them that, just because we don't directly have the money coming to us from the insurance company, it doesn't mean we can't do the paperwork. It doesn't mean that we can't pre-authorize things. It doesn't mean that we can't tell you how much your anticipated bill is. It just means that you're going to give us your credit card and the insurance is going to pay you back, right? And educating them on that is I think, very, very key in being able to drop PPOs. Leslie, we're going to change it up a tiny bit and start talking about, do you have anything to add to that?
Oh, no, I was going to say, I agree.
I would love it. Okay. And if you guys do, just do this and I'll say, yes, absolutely, because this is supposed to be a great conversation. Leslie, we're going to talk about regulatory changes now. We've got a lot to cover. We got a lot of questions in an hour. So we're zooming around. I hope everybody's got a pen that's listening or is rapidly writing down notes because there's some great tips here. What new challenges or regulatory changes might dental offices face when incorporating medical billing in 2025, and how can they proactively address them?
I think as far as the challenges are concerned, we need to document a little bit differently. When you come from an oral maxillofacial surgeon, you're used to the subjective objective assessment plan, that SOAP documentation. And I believe that the more, medical gets in our field, as well as the more ancillary product, services we are providing, documentation is going to be one of the challenges, making sure you're documenting, to the level that medical insurance requires. And then continuing education. You need to know, what is covered? What are my responsibilities? How do I file it? So that's why, continuing education for your administrative team is important, because a lot of times the doctor will get special training on, maybe it is obstructive sleep apnea. They give all this clinical training, but they need admin training as well, because there's certain layers that are going to be addressed. Now, even with your practice management, I think that's going to be a challenge too, making sure that you are able to file those medicals. They have the capability, but the actual clearinghouses is what we'll have to talk about as far as a challenge there. And then also, as far as regulatory, Shelley, I think it's a big thing to know, what is the No Surprise Act? What is a mandatory, filing law with Medicare? What do I have to do? Because if I am stepping in that arena, I need to know what all the rules are. So that's going to be one of the challenges too, is making sure you're aware of what is required.
Those complete notes are just going to help you more and more and more as time goes on, right? No matter, and your staff. You hit on something very, very big there that isn't something that I get a chance to touch on very often, and that is that admin staff training. An office that I was working with was doing implants, and nobody ever talked to the front desk. They had just done all of these courses, invested tons of money on those opening kits and tools and everything. Nobody had ever talked to the front desk on how to talk to a patient who's calling for the implants that they're now advertising. So they had no idea what was going on. The crossover opportunity that you have there is incredible. So it's such an easy thing to overlook. Why would my front desk need to know anything about implants? Because they're selling implants. That's why. Thank you so much for that, Leslie. Anybody want to chime in on that? Nope, we're good. We'll move on to the next one. And the next one is for you, Janelle. As a dental hygienist, have you been called a teeth cleaner or the cleaning lady?
Oh, yeah. I've been called, and it's usually with my older patients.
Yeah.
They're super cute, but I have been called the cleaning lady, and I have been called the teeth cleaner. But one time it was actually interesting, because one patient came in that all I had down is his health history. And I was filling in at this office, and all I had down on his health history was hay fever. And he comes in, and he's probably, later 60s, in his 70s. And he had this huge abscess with tooth number 2. And I was talking to him about it, and I said, well, this is not good to have this infection. It can be related. It can affect your heart. It can also affect, like diabetes, blah, blah, blah. And he says, oh, I already have all that. And I was like, whoa, wait, I do not see that on your health history. So I had to stop.
I didn't expect that answer.
Yeah,
That's awesome.
I was like, whoa, wait, I just have down hay fever. What's going on? And he's like, oh, yeah, I have heart disease and I have diabetes. And I was like, okay, what's your, how's your blood sugar? Do you take it? And he's like, no. And I was like, well, have you been to the doctor? Do you have it checked regularly? Because they check it quarterly with the A1C. And he's like, no, I don't. He doesn't care. And I was like, oh, okay. Now we need to have an education on infection and uncontrolled diabetes, or just diabetes and how you're not going to heal, blah, blah, blah. And he was like, he stopped for a second. He looks at me and he says, you're more than just a teeth cleaner, aren't you? And I was just like, yes, I am. And I didn't go into an extent of my education and my experience, but I just kind of kept focusing on him. But when the dentist came in and said, oh, yeah, you need to have that tooth extracted, he was just like, pretty soon. And I just chimed in. I was like, no, I said, he's diabetic and he doesn't know what his levels are. He doesn't know if it's uncontrolled. And the dentist just looked at me and paused, and he said, you need to have that tooth out now. And so it was just kind of interesting how, we can help try to educate patients to understand that there's this connection, and we And I know that even as a teeth cleaner.
So is there, this isn't on the list of questions, but do you think that there are ways that we can do that? I can think of a lot of ways through marketing that we can do that. And the things that you're putting on your website, I'm going ding, ding in my head. But are there ways that the office can do that? I mean, obviously we can have the front desk talk about the hygienist slightly differently. So Janelle, do you have a couple of tips for that? And I know I'm putting you on the spot because I didn't ask you for tips before we talked.
Oh, no, that's okay.
But I know you've probably got a couple.
I know it's difficult when when I go to offices where I'm just filling in, I try to educate my patients right at the beginning because they're seeing a different face. And I mean, I think that's really good since right now, hygienists are doing a lot of filling in, temping work. It's becoming a bigger thing. So I like to reassure those patients and also the office. So when I am setting up an appointment, I'll let them know, like, okay, I have 22 years experience and I've done this and this, and, I have a bachelor's degree in this. And so I just kind of let them know, but then also to just reassure that patient, I let them know, that I'm well educated and that they're in good hands, and it just reassures them and then helps to build that trust, even if it's for that day,
for the whole visit at the office, right? Because if they're building that trust with you and your experience and your education, that will convey over to the dentist who comes in for the check, right? It's hand in hand. Yeah, absolutely.
Yeah, and I don't like to just go right into the cleaning. I never pick up a scaler first. I always pick up an explorer or my probe first. I'm always going to be asking questions. I go over health history first. I do the x-rays. I ask questions about that. I ask their pain level. Then I'll go into the evaluation and then ask them more questions about that. So we try to make sure that we're finding that, if there is an underlying disease, I always check for sleep apnea as well. I have a history with that, with my daughter being diagnosed with sleep apnea at 9 years old. So I've done a lot of research and I try to help my patients with obstructive sleep apnea. I kind of try to do more and more. And I have had patients, one patient that, I was temping in an office and I saw a new patient and he stopped me because I was just going into all this prevention. And I kind of stopped and said, you know what, I'm so sorry. I'm filling you with so much information right now. You're probably overwhelmed. Let me just clean get the teeth cleaning done and we can talk more when I sit you up. And he's like, no, this is the best appointment I've ever had. I've never had a dental office talk to me about prevention. It's always been, you have this cavity, drill and fill, and never tell me how to prevent it. And I was like, oh, I kind of felt bad for him. But I was like, well, I'm glad that he was enjoying the experience.
Yeah. That makes a lot. Thank you so much. All right, Tessina. How do I know if it's not time to negotiate my fees?
How do you know if it's not time to negotiate?
If it is time. Sorry, I did.
If it is time.
My mouth did a whoop.
I was just trying to figure out where we're at. Okay, how do I know if it's time to negotiate?
If it is time, it's always time.
It's always time. With the insurance companies, each insurance company kind of has their own set rule of how often they will allow you to be eligible for negotiations. Right. Some insurance companies actually allow it every year, while other insurance companies are every 2 years or 3 years, right? So take time to make a spreadsheet, take notes of this, and follow up every year. And some do it in July, some do it in January. So be aware of those trends. Make sure you know for your area, for your insurance companies, when you are due to negotiate your fees. Also, take into consideration, even if they do it every year, do you really necessarily need to increase it every year? I mean, we'd love to say yes, but sometimes there's a little bit of a problem if you're increasing fees every single year with the insurance company, because it can take several months for them to get that into process. And then they have to reprocess some claims. And then, I mean, it can take 6
You're
months
just
to
in a
work out.
constant cycle of upside down. Yeah.
Yes, a
Yeah.
little bit. So I just make sure you know what company you're working with and how smooth of a process that can be. If it takes 6 months to get the fee schedules in place and get everything reprocessed, and you're constantly making this work and this juggle of processing claims, readjusting claims, and patients going, wait, I thought it was what fee? That can be kind of exhausting for you to do that every single year. So is every other year okay? And it might depend on where your fees are at. If the fees are super low, and some insurance companies will only give you a certain percentage every year, if you're way off the mark and you need to be over here, maybe you have to go through that struggle every year so that you can get to where
Until
you need
you're
to be.
there. Yeah.
But
Yeah.
if you're at the higher mark and you're just wanting more, maybe every other year is satisfactory for you. So I don't want to be, not that we're greedy. You guys need to be paid for your work
No,
done
but you
in
need
most
to
of
pay,
these
you need
things.
to pay for things.
Yes, we need to pay for things. It's not about
Yeah.
being greedy, but like, let's take that balance into effect. Is that $5 difference that, you know what I mean, really gonna make the increase that you need for this year, or can you do it the following year? That and being familiar with those insurance companies, what percentage on average do they give you every time they do an increase? So again, some of those are set tiers of like, if you're on this fee schedule, I can't jump you from this one to the third one up.
Right.
You have to go step by step. Those ones you really don't want to miss. Other companies are more willing to take into consideration your specialties, your fees, how things have changed, and they might give you a 3-bump tier, right? So taking those things into account of when do you need to negotiate fees, and when will the insurance company allow you to?
I loved your comment about a spreadsheet type thing. I mean, at least start there. Everybody's got Google Sheets for free these days. Start there. And the thing I want to add to that is give yourself copious notes, right? We talked about medical charting notes before, or dental charting notes. Give yourself copious notes, because if you're going to look at that in 18 months or whenever the trigger comes up that you're supposed to have that, if you serve yourself by making notes of what happened last time and what you want to happen this time, you will reduce the amount of time you have to spend on it exponentially. Do yourself the treat of making notes for yourself.
Yes.
Yeah, absolutely. Leslie, how can dental practices adapt their strategies to maximize case acceptance? I love this question. And revenue by utilizing medical benefits effectively in the coming year. This is new stuff. This is why I like this question so much.
Okay, well, first of all, utilize their medical benefits that they are entitled to.
Utilize it. Yeah, start.
Exactly. So one good example is if you use a light illuminating oral cancer screening device, that goes under the patients typically. There's so many different type of plans. Yep. They're preventative, so there's not a deductible. I usually see those oral cancer screenings getting paid like $85 for the actual screening, as well as the medical, the exam. The medical decision-making process is reimbursed very well under medical payers, usually 3 digits when you're looking at that versus a PPO adjustment. So utilize their benefits. Are their teeth impacted? The specialists you're working with, are they getting medical benefits first so that they free up those dental benefits for you in the dental practice? You're seeing OMT, your oral maxillofacial therapy covered under medical. Like I said, the cancer screening. Also, if they do not have dental insurance, ask for their medical insurance information.
If you can bill it. Yeah, exactly.
Yeah, there's usually dental riders in there. If your patient's pregnant or if they have diabetes, there's usually dental coverage embedded in their medical plan. So first file it and utilize it. And then you can also educate your patients on how to get their plan benefits offline, or we can sometimes get them as well in their HR department. But first of all, recognize that there are more benefits under medical than people think. So if we can, in majority of the cases, you can't always say always, but in the majority of the cases, your medical is primary and your dental is secondary. So frenectomy, anything soft tissue, was an implant placed because patient is a late effect of trauma, that baseball injury, years ago, and the root canal's failing. Utilize the benefits and before you utilize their dental plan.
Amazing. Thank you. Do have a couple questions that are coming from the audience that are related to what we're talking about right now. So I think it's a good time to pull it out. I have, and I know Tessina is going to jump on this one. Do you know if Delta allows fees to be negotiated? I was under the impression they no longer accepted negotiations.
Oh, this is a hot topic.
It is. That's why I'm reading it out loud.
So it depends on the city and the state that you're in as to whether or not Delta Dental will negotiate. And if you're in an area where Delta Dental is not negotiating, then you will need to make some decisions as to how you want your relationship with Delta Dental to be. And if you want future opportunities for negotiations, just like any other insurance company, like we talked about before, you have to look at dropping that plan, being an out-of-network provider. That is what brings about change for all insurance companies, and Delta Dental is no different. If you're in an area that does not negotiate, that's because they have a heavy flow of providers and they don't see a need to make a change.
Really and truly, that's truly the answer. Try. Try for sure. Here's another one. We participate with a third party this is a good question because a lot of people are going to be in this situation, that has several insurances under one umbrella. How do I navigate that? Anybody chime in with some great tips? Because it's a hard thing to do. It is.
Yeah, umbrella networks is like my specialty. I love it, actually.
Oh, yay.
It takes a lot of work. So she's saying the question is that they're in network with a lot of umbrella networks and it's becoming a mess.
It doesn't identify, but it says an umbrella. It doesn't say umbrellas. It says an umbrella. Yeah.
Okay. All right. I'm trying to reread the question in my mind, but okay. If you are in networks with umbrellas the correct way, it's a really beautiful thing. It can be a great thing. You can get higher fees and you're in network with these other insurance companies. It's an indirect contract. So you're not directly contract with the insurance company. You're contracted through the third party of the umbrella network, which means you're also telling the insurance company, the direct insurance company, that their fees were unacceptable and you had to go to a higher umbrella. However, all of these insurance companies have started getting into the business of selling their fee schedule. So we have really low paying fee schedules being sold, and offices are not sure or aware of how they keep coming up. They're coming up at a huge fast pace right now, where it's just every month, every couple of months, you're getting another letter that another company is selling their fees. Again, if you are contracted on a plan with really low fees and then you're mad that they're selling those fees, I go back to the question of why were we taking those fees? Right. Get out of that plan. Don't take those low fees. But you can reach out to the insurance company and tell them that you do not approve of them selling those fees. In most cases, if it's not a direct ownership, they will not be allowed to sell those fees. Sometimes the company selling the fees also owns the company they're selling the fees to, or has some ownership in there, and they may not allow you to do what's called an opt-out if they have some ownership in that other company. So they're saying it's at that point, it's the same as a direct contract. So now we need to evaluate, do we need these fees? Do we need this plan? And the answer, I bet you, is no, you do not. But I teach on that all the time. So
thank you very much. Yeah. So contact Tessina.
Yeah.
And we will have the information for contacting everybody shared again at the end. So, you've got some great minds here to be talking to for sure. Let's switch back over to hygiene. Let's talk, and I'm going to tie this question in with some things that you were talking about earlier, Janelle. And that is when a lot of temping is happening. And I think this question ties to that a little bit. And the question is, as it's posed, as a dental hygienist, do you feel confident is what is being billed to insurance? And the reason I bring up temping is you're seeing a ton of stuff across a lot of offices, and I'm sure that very little actually matches. So I think that the layered question that I'd like to then make it is, what are people missing on billing that they should be billing?
Yes. So actually, this just happened at an office I was temping at this week. And I don't know what the patient's insurance, or if they were a cash pay patient or not, but they had billed out 3 quads of SRP, scaling of root planing, and then the other quad was a D4346. And I was like, no, you can't do that. So, I mean, I'm filling in that day. So it was hard for me to say something, but I said that code right there is a gingivitis code, and it is also a full mouth code. You cannot bill just a quad, and you can't bill it when there's periodontal disease. So that's hard. I don't think people really understand the D4346 code yet. So I would suggest that hygienists, dentists, that you read your CDT book, understand the codes, and make sure if it's a full mouth code or if it's a quad code, and make sure that you understand what you can bill. And when things change, especially like I had to reach out to Tessina because I billed out a full mouth debridement with a comprehensive exam. And I was like, well, I know that we can now bill out exams with the full mouth debridement, where before we weren't able to. But I wasn't sure on I wasn't sure on which exam. So it turns out that we had to, figure that out and rebill it, since the full mouth debridement can only be billed with a limited exam, right, Tessina?
Got it.
So there are a couple things that
I hope you had a glass of wine while you sort this out.
Right. So as things change with codes, make sure that you understand them and that you know the change. For me, as a hygienist with working with different offices, it's difficult when you're working with some offices where the office managers don't understand the insurance enough, or are not billing out the right codes and just billing out the simple, like everyday x-ray, exam, and cleaning, right?
Right.
And that's all they bill out, because
Or
they're
relying too much on that combo button.
Yeah.
Right?
Yeah.
The combo
I'm like,
button, and
no,
then not putting the procedures that are outside
Yeah.
the combo button because
Yeah.
we're really busy and we got to run to the scary center.
So, and
And then
I
the front
actually
desk
put
says-
in all my codes before I walk the patient up. If it's a combo code, if I add another one, if we're doing pulp vitality testing, I'll add that. And if we, taking intraoral pictures, I'm adding that. Like I add all these extra codes. And then sometimes I have to explain that to the office manager or the girls up front that are doing the insurance billing, and like, okay, no, this is how you have to bill it. So it helps me to keep things on track and make sure that it's being billed right with what I'm doing, and it's not coming back with having to explain all of that information.
And all of that in a temp situation becomes like so exceedingly important, because you're trying to fit into this scenario that you don't work in every day, and you can't be back next week to explain.
Yeah. And I tell them like, okay, I did this, and they're like, oh, okay. And they just bill out like the usual stuff. I'm like,
Exactly.
okay, I kind of, sometimes I just have to like, just do my job and, but at the same time, like make sure, like I try to make sure that the codes are right as I'm walking the patient up front, that they're not billing it wrong. So
that's awesome. I don't know who else wants to hire Janelle, but boy.
Right? I've worked with Janelle. I love Janelle. But a lot of hygienists are not aware of the coding that goes in place. They just try to do their documentation, or they just try to do their notes. So for us in the front office, we need to be asking a little bit more of like, okay, what exactly did you do? We need to have a plan in place for our regular hygienists and for our temps of this is what we like to see. And we want to know about these things that you did so that we can code properly on our end and capture those opportunities. We need to be posing that question, because the hygienist may not know how to code it. She's like, okay, I did this and this, and I put it in my chart notes, and she's relying on the front office. He or she, is relying on, I'm thinking Janelle, right? They're relying on the front office to take it from there. And Janelle's awesome because she keeps track of those codes herself, but not all hygienists do. And I think there's this gap, right? We got to bridge the gap.
A really, really, really good procedure to put in place that you can go over these things as a morning huddle and go over what's happening and what you're supposed to be billing and all of that, so that you get it cemented. really, really well.
Better than
Really great reminder.
Yeah, better than that, I recommend a hygiene tracking sheet. So the
Oh,
hygienist
amazing.
writes on it, and or what do we call it, Leslie? Like a routing slip or a patient
Yeah. Oh,
pass off,
yeah, yeah.
right? Yeah. So
Yeah,
you
some
have that.
software has that built in now, and it comes up
Yes,
before
it
the chart
does.
opens.
Yeah, but you want to customize it for your office so that you're having the hygienist mark the things that they did, whether it's a temp or your regular
Yeah.
one, and they bring that up with the patient, and then the front can put in the correct codes.
That's awesome. Thank you. Leslie, I have a question that might be going down your path here, and I think it's a good one. It's how do we bill medical insurance? This came in from the chat for a sleep apnea appliance.
Well, oral appliances for obstructive sleep apnea are even covered under medical, depending on what appliance the patient qualifies for. So the reason I bring up Medicare a lot is because of the trickle effect. When Medicare does something, typically the other payers kind of follow suit. May take a couple of years, but they do. Medical with obstructive sleep apnea is probably one of the easier procedures to file to medical, and the turnaround time is usually less than a couple of weeks as far as your reimbursement. There's only a handful of codes, depending on what appliance that patient qualifies for. It's knowing the diagnosis. So the difference between dental and medical is they want to know not only what you did, but why did you do it? And that's the important thing. So if they do have that diagnosis of obstructive sleep apnea, then the G4 7.33, then that is going to make that medical in nature. And you have to make sure that you have the proper steps. Did you get the order from the physician? Are you documenting, the little sticker that they get from the appliance? Is that put in the patient's paperwork? Since it is limited on the amount of codes, it's probably the easiest thing to learn, which is why I do have the dental classroom, is because there's an entire module just on that. You can also outsource it. That's an option too. That's why I have that as an option too. However, I do find that other than like oral and maxillofacial surgery, where you're doing condylar fractures and lacerations and open and closed and all that, it's one of the easier things to get covered. It's just getting your doctor credentialed properly, knowing that really electronic claim submission is going to be your best bet. And you can do that for free. You don't have to purchase any new software, et cetera. So how do you bill it? I've got a list of the codes for the appliances, and I've got a list of the diagnoses that I'm happy to share with you to get
Amazing.
patients the benefits they're entitled to. And Shelley, if you don't mind, I'm also kind of reading in chat about the in-network versus out-of-network deductibles. So it's a good time to kind of go into that as well. I recommend you get out your own medical insurance card, call for your benefits, because their language is a little different. They're going to say in-network benefits $500, out-of-network benefits $1,000, but still what was applied to the in-network gets applied to the out-of-network as well.
Right.
So once they hit that maximum, then you're fine. You also may find that there's not a doctor in a 25-mile radius or whatever their criteria is that is in network, so you can get out-of-network benefits. Now, you may not want to do a gap exception where you have to do, write-off. That's a total different subject. But call on your own card just to get an idea of what the differences are. My sister, she's married to a farmer, so they're looking more at a $5,000 deductible, and a $10,000. So you may be able to get in-network deductibles if there's not a provider in your area. Then the patient shouldn't be penalized for that. But just knowing that there are, that language that you need to be aware of, just call on your own card. And then another recommendation I give in classes is, gather medical and dental insurance cards for the next couple of weeks so you know who your major payers are. So if you are providing, sleep apnea appliances in your office, know who your big payers are, get credentialed, and get ahead of that.
That makes a lot of sense. We do have another. Oh, yes, please, Tessina.
Sorry, I just want to add one little thing that I dabble very little in medical billing. I'm not the guru that Leslie is, but
you have a unique hobby.
Yeah, that's right. And I love it. And it's been super fun. And I work with a lot of providers in general dentistry, so we're not heavily billing to medical, but we definitely love to dabble in it and bill to it. And there are several options to do it without being credentialed. Some insurance companies have waived this in-network, out-of-network problem for us because I was able to explain that we're a dental office. We don't typically bill to medical, but this is the situation. The patient had to be treated at our office for this, and it is medical in nature. And so we were just able to appeal that and get some exceptions made, a little bit more work there. But surprisingly enough, a lot of the companies have the out-of-network coverage, so we didn't have to run into it tons. And then when we did, we would just try and appeal them without getting credentialed. But I love the idea, if you know you're going to be relying on it a lot and you're going to be doing it a lot, then you should go that route, so then it's easier for you.
Now, do remember too that is, contracted. You don't have to be contracted, then you do have to be credentialed. So you do need to be in your CAQH through the ADA. I mean, credentialing and contracting, but you're absolutely right. Like most of the providers I work with are not going in network. They're not getting.
Yeah, they're out of network.
They're exactly,
Yeah.
but So you have to have the credentials, but yes, when it comes to contracting, don't feel like you have to go in network and start. We're already been discussing getting out of PPOs with dental. You don't want to.
And they pay much better, just the same as anything, right? The fees are better because you're not contracted to that fee.
Yeah, and
we could almost carve this out as its own subject, right? Like there's so much there really is, all of them, right? Umbrella ones, this one, there's so many paths you can go down. Sorry, Leslie, I think I interrupted you and I apologize.
Oh, no. I'm just looking at the chat because, it is true that, as far as the out of network, whatever, but there was something in here about, do patients need a referral from the physician first?
Yeah, I was just going to bring that one up. Yeah.
And the answer is, it depends on the payer, but majority do want that. So Medicare, yes, I can say yes to that. But the other different plans, it's best to have some type of a referral or a relationship with a physician, because a lot of times they've tried the traditional, CPAPs, and they just can't tolerate that. So they're now going to an oral device. So
that makes sense.
Helps.
we have a follow-up in the Q&A for you as well, Leslie. It says, you mentioned that in June Medicaid will begin requesting modifiers. Can you elaborate on what procedures they will be requesting, if you know?
That is for me to see yet, and actually Tessina may know more on that, but usually it's the KX is a lot of the ones that we're seeing that they're going to start requiring, and that's just that you did go through your proper steps of documentation properly, et cetera, and to that level of detail that they're requiring. It's just the problem we're going to have is if your clearinghouse allows it. Your software may, but is your clearinghouse allowing it? So just being a little proactive, and you may have to go to the portals to put that in during that transition if your clearinghouse isn't allowing it. But I see a lot of KXs being required, and definitely send me an email if you have any more questions about that, because I have a list of the modifiers that may be required. And some of them are going to look very familiar to the offices that are having, adding sleep services. They're the same. So
awesome. And I am going to wrap in just a minute with everybody going over what it looks like when we contact you, but we're going to put one last question in. And it is, you mentioned that some codes are billable, but the insurance may put a max amount. Do we have to bill it to insurance, or can we bill directly to the patient and tell them that we don't bill this code? For example, OHI D1330 or nitrous D9230. I knew Tessina was going to be like,
okay. I'm like, all right. So this could be a loaded question. I'll try to wrap it up. I know we're like going over time.
No, we've got till 5 after the hour.
Okay.
We've got till 5 after. Yep.
All right. So technically speaking, insurance companies are stating that if you're contracted with them and you're aware that that patient has that insurance, you are required to bill to them any services that you do, even if they're not covered. You are still technically required to report that to them, because they want to take the opportunity to see if there's any savings that should be applied to the patient. So if you're not billing it to them, you could be in some violation of that. That being said, is it happening all the time and nobody's really getting caught in trouble? Yes, it is. If you don't want to bill something to insurance, again, that's not showing the insurance company the need to make the change for that code to be covered. So I don't love that plan. But if you're really seeing it become a problem and you don't want to bill it to insurance company, I recommend creating your own code, a non-descriptive code, and just explaining to this patient that it's not a covered service, it won't be billed to insurance, and this is your office fee for it.
Makes a lot of sense. Janelle, if people want to get in touch with you, and I'm sure the team will share in the chat the contact information for you as well, what does it look like when they get in touch with you? What can they expect?
I guess it would depend on what their needs are.
Right.
And what their focus is on. Are they wanting to, like restructure their hygiene department? Are they wanting to, do more of a team effort? And, it just depends on it. Are they wanting to work on filling their schedule? Are they wanting to make sure they're diagnosing correctly with periodontal disease and with the gingivitis codes? And also, like, do they want to look at sleep apnea more? Do they want to look at, and there's a lot of things that hygienists can do. Another thing I was going to plug in there, we have been talking about not only just sleep apnea, but I like to make sure as a hygienist, that I do a thorough report on that. If that patient has, they don't know if they haven't been diagnosed yet with OSA, if they haven't been obstructive sleep apnea, then I look at all the signs and symptoms and I take a thorough documentation of it. But I also look at where they're at. Do they have high blood pressure? Are they on blood pressure medications? Because that is a factor. If they have sleep apnea, they're most likely going to have high blood pressure. So there's different health issues there. Another thing that I have found in some states, when I worked in Oregon, some insurances were paying for more cleanings per year. If I had a patient come in their early pregnancy, they were allowed 3 to 4 cleanings that year. If you have a patient that's diabetic, look at their insurance, because most likely you're going to want to see that diabetic patient every 3 months. Okay. And sometimes insurance companies will pay for 4 cleanings a year. And I saw that mostly in Oregon when I worked there. but I was willing to help utilize the insurance. And like, all they have to do is show that they've been diagnosed with diabetes and report that to their dental insurance, and then they can get those cleanings covered.
Thank you very much, Janelle.
Yeah.
Much appreciated. Tessina, if people would like to get a hold of you, what does it look like? The team will share your contact information.
Yes, perfect. Reach out to me. Let me know, like, similar to Janelle kind of just said, it depends on what they're looking for, what they need. I have a wealth of different options for them available, whether it's admin, coaching and training, whether it's insurance verification, fee negotiations, which I do alongside sometimes with Ben at Veritas. But so there's several options. Whatever they're needing, reach out. Let me know your struggles. Let me know those barriers you're coming up against, and let me help empower you to break down those barriers and make those changes long-term for everybody. As I'll join in and start making those changes, then it changes across the board for everybody.
I'm going to pop in before I slide over to you, Leslie, and I'm going to say, if you guys want to contact, in case anybody has to duck off or anything, Equa does offer meetings as well. You can get in touch with me and go over some of these ways to get rid of PPOs. They'll share that information. We also have a segment coming up that I'm so excited. My coworker Lila is going to join. It's impossible to get her to join these, so I'm very excited that she's going to join us. But just in case, we'll pop my info in there too. And Leslie, how are we getting a hold of you, and what are you going to do for us?
When someone reaches out to me, I will send them a calendar link to schedule a discovery call. Yep. Because, are you needing outsourcing? Are you needing training? So I have a discovery call, and I have a lot of availability. I try to, make myself available to as many people as I can, because my goal is really to get the patients the benefits they're entitled to under medical, and help dental practices understand that if I can do it, they can do it. It's super easy. And so I would schedule a discovery call, Shelley. That would be my first thing.
And I think the takeaway is that none of us are going to charge you for contacting us. Reach out. We'll do our best to help you wherever we possibly can. We're all very, very invested in the industry and in helping people. And ultimately, really, at the end of the day, we're all helping the patients, right? That's what we're all here for. Ultimately, that's what it's about. We can't keep our doors open. We can't. Next up, we have Ben, who's going to join us. Ben, are you there? Thank you, ladies. I cannot
Hello,
wait till the next
hello.
time we get to meet again. Hi, Ben. How are you doing?
I'm doing well. I got to say, Janelle, Tessina, and Leslie, that was very awesome. Your answers, I learned quite a bit, and I'm super excited to share my part after hearing such great information from these wonderful ladies. So thank you again for that amazing content.
I love that
So
you
shall we
carried
dive
the theme.
in?
Absolutely. I want to comment that I love that you carried the theme with the background right over to the shirt. I think that's fantastic. I expect there to be a surfboard kind of happening in the background there.
If you've ever watched the movie Maui, that is Tafiti right there. Those
There
are
you
her
go.
hips that are at the high point to the left.
Very
So
beautiful.
that movie Maui was kind of crafted and created based upon my home country of American Samoa. And I live in Dallas, Georgia now, and we had a tornado over the weekend. So forgive me if I get delayed. Not all the communication bandwidth is back to normal yet. So
Are you and yours okay, Ben? That's the most important thing.
Oh yeah, there were no fatalities, fortunately for our community for that tornado, and so it's just been mostly removing trees. That's just been the tough challenge.
The sound of chainsaws, yeah, absolutely. Without further ado, Ben, would you please please enlighten us? I'm looking forward to your presentation as always.
Absolutely. So this will be a short presentation. We're going to go for the next 20 minutes here on 15 minutes on the current state of negotiations in the insurance industry. And you know what's interesting these days, Shelley, is that the insurance carriers, they seem to be in desperation mode. There's so many doctors going out of network these days, and that's causing, in my opinion, a correction as it pertains to dental plans, from reimbursement levels to what they're selling to employers. There has been a little bit of a temptation for insurance carriers to reduce out-of-network benefits or to minimize out-of-network benefits, sort of as a way to get back at the doctors for the wave of out-of-network that's currently happening now. But every insurance carrier that tries that, it seems to backfire in a big way, where the employers protest greatly simply because it's unfair to not give patients an option to choose to go anywhere they want, regardless if it's in-network or out-of-network. And I know that out-of-network, if employers consistently have their people going out-of-network, it does raise the premiums for them. But that's not a big concern because it's actually not a big difference in terms of what the employers are committing. And I think this is good because it is important for people to know. It is important for the employers and patients to know that the dental community has just been abused by these insurance carriers for the last number of years. Now you have voices like, myself, like Janelle, like Tessina and Leslie, and many others that educate doctors about this whole realm of insurance. Well, guess what's happening today, Shelley? Is they're going after people like us. The insurance companies are attacking people like Tessina, people like me, the part of us providing education that is influencing doctors to make changes in their practices. And the part that the insurance industry doesn't like about people like us is the fact that doctors are responding to the call to go out of network. And we make this call because the industry is ripe for correction. We've seen the stock market here in the United States.
It's controlled by insurance, right, Ben? It's not supposed to be.
Yeah, it's not. It's not. And so the correction that's going on right now is forcing a lot of uncomfortable, it is very uncomfortable for all parties. So like the insurance industry as an example, I use the word conspiring because it's true. The insurance companies, they do have planning meetings together. There are components of antitrust that are enforced against the insurance industry. And so you do see them talking with each other on what's working. How do we get doctors to stay in network? And it's more so, how do we trick them to stay in network, And so what I'm seeing is that you have these umbrella network affiliations that are changing. Many of you have probably received a notice last year that Cigna and Dental Health Alliance, which is DHA, they also go by the name Assurance and Sun Life, they entered into a leasing partnership. So you see a lot of that happening these days, but you also are not hearing about a lot of the insurance carriers that are backing out of umbrella network relationships. So there was a question that I think Tessina answered it in the insurance panel session about umbrella networks. And, not every umbrella network is made equal. Some umbrella networks have more ownership, into other companies to where you do not have the ability to opt out. Some umbrella networks only give you 3 options and say you can only opt out of 3 plans. And then some give you a lot more flexibility there. But what you're finding these days is that the individual companies that used to use umbrella or certain umbrella networks are not giving public notices out there as it pertains to those types of changes in the contractual world, at least on the umbrella network side. And I think most of us are familiar with the No Transparency Act that was passed, what was it, 2021 or 22? No Surprise Act. It was the Transparency Law, the No Surprise Act, that was designed basically to force the insurance companies as well as the hospital systems and the doctor community to do a better job at giving patients better estimates for out of pocket, right? But we researched, I'm not sure if anybody's is aware of this, but there was an executive order that just came down from the White House recently about enforcing full measures on this No Surprise Act. We've researched it extensively. And so this is not the final determination, but as we reviewed the No Surprise Act, as well as the current executive order, there's nothing mentioned about whether that's going to be applied to dental offices or not. But what you're seeing is the insurance industry is still not responding to the No Surprise Act on the dental side. We are still in a mess as it pertains to understanding what the in-network or out-of-network estimated out-of-pocket are for patients, right? So what I'm trying to get at here is that insurance is naturally designed to be confusing for patients and for doctors, mostly to make room for mistakes on what the patients pay, what the doctors pay, and then insurance carriers. And I say this because it's the truth. So if you work for an insurance carrier and you want to send me a lawsuit, bring it. We've dealt with them many times and we'll still deal with them. But the reality is that the insurance industry seems to be taking advantage of the lack of data that's given to patients in the dental offices as it pertains to coverage. So there's millions upon millions of dollars that dental offices subsequently write off unnecessarily. And that's a direct result of sort of policies as well as insurance carriers not being committed towards helping us help our patients, right? And you would think those patients are equally ours and the insurance carriers. Dental offices make money on those patients and the insurance companies do. You'd think that there would be an equal amount of effort to make things easy on patients, but naturally, it doesn't seem like those measures will ever improve. Now, moving on to the next bullet point, you do see a lot of insurance carriers these days desperate to negotiate. And the criteria is if there are fewer providers that are in-network in any given community, you do see those insurance plans desperately trying to recruit and negotiate to retain or add more new doctors to the network. Most doctors, like if you're in a rural community or even in a city, and you're one of maybe a few doctors that are in network with that dental plan, if you're going out of network, you may notice that these insurances are coming back to negotiate with you. I'm not going to name names on these insurance carriers because it's just interesting to me that, rather than addressing these issues, they intimidate organizations that are trying to help doctors. So in the end, as it pertains to this whole world of the rural negotiations, if you're one of a few doctors, if you initiate terminations with insurance carriers, it is opening the doors for negotiations. But in the cities, there are, most insurance carriers are struggling to keep up with provider percentages, in-network provider percentages, because when plans are sold to employers, the insurance carriers promise to maintain a certain percentage of in-network providers. So that particular client or that employer would have options for their employees to see a number of in-network providers. And now you're seeing insurance carriers sort of desperate to maintain that threshold. And some of them at 60% of all doctors in that area, we need to have 60% in-network. And so you do see those measures of insurance carriers desperately negotiating, trying to retain those that are going out of network. But for those that are coming in network for the first time, that's also a good opportunity to negotiate fees. And be patient with that. It's interesting that when you look at the dynamic of negotiations, on one of the next slides here that I'll share, is that very few practices read through all the contract language. Very few doctors read through the entire in-network agreement. And insurance carriers are giving fee increases. And if you negotiate properly, you're getting record level of fee increases these days compared to even 2 to 5 years ago. But one of the things that the insurance carriers are doing is, they're negotiating these higher rates, but they're inserting contract language that tricks you. One piece of contract language, it says we reserve the right to change these fees at any point throughout this next 2-year agreement, which means they could lower the fees in 6 months to a year. In addition to that, what they're saying is, oh, and by the way, you cannot terminate this contract for a 2-year period, and you agree to not negotiate for 2 to 5 years, right? So they specify those things. Well, several insurance carriers have been testing this new type of contract over the last 2 years. And so they've been playing around with it. Some doctors are getting 24-month non-termination, non-negotiating agreements. Some are getting 3, some are getting up to 5 years. And keep in mind, once you sign those contracts, if you haven't read them, you are agreeing to those terms regardless of whether you read or understand them. So pay attention to those items. I recommend striking those clauses out. I just heard over the weekend at another conference that striking out contracts still doesn't necessarily work if the insurance carrier still honors the contract, because the insurance company doesn't initial the part of the contract that you terminated. Well, I got to thinking after I heard that, I was like, you know what? I just recently bought a house and I initialed all the components that I was required to initial, right? Even the changes I was required to initial, but the other party, they didn't have to initial those same things. All they had to do was sign the bottom of the contract to acknowledge the changes that I made in the agreement. And it's interesting that I'm hearing, I don't know if this is being pushed down by the insurance industry, but I heard from somebody who I thought was a prominent educator on our side of dentistry in terms of helping doctors. I heard the opposite, that said those things don't even work either. But the funny thing is when I talk to our attorneys and all the other attorneys that gave me that same advice, we've actually have evidence to indicate that when you do strike out a clause and you initial it, and the insurance carrier signs the bottom of that contract, they acknowledge the contract exactly how it was written or how it is written at the time of the signatures, right? To where both parties at that point are agreeing to a bilateral agreement, which means both sides can edit the agreement and come to terms on what both will accept. But in the end, that's the solution, is you have to strike out these terms that you don't agree with in an effort to avoid being abused by these insurance carriers with terms that may be uncomfortable for you. The other thing is setting up the fees at the right level. You know, there are multiple different systems that you could use out there. We use NDAS, and as a gift to those that are on today's webinar, email us directly. We'll give you the NDAS percentiles for your community. Now, among the NDAS percentiles, I recommend being between the 60th and 80th percentile. If you're using the Fair Health percentiles, which is another great database to use, I recommend the 80th percentile as the minimum benchmark. But if you're uncomfortable with those terms, you know, in my opinion, naturally you want to incrementally raise your fees over time so that you hit those higher benchmark levels, mainly because when I look at data for practices across the country, it is very clear that the lower your fees are, your standard office fees, the lower your reimbursements will be with insurance carriers. And the opposite, that works as well. And then, you know, when it comes to out of network, I agree with Tessina, is out of network. If you do it the right way, out of network is very beneficial. It is what's causing a course correction these days with insurance carriers, in the sense of the insurance carriers finally feeling pressure to be better with the doctor community and the clinical community. So here are some stats that we've been tracking. This is actually interesting is that when we look at pockets around the country, when we send polling data to, this represents about 22,000 dental practices in key major cities throughout every region of the country. Only 38% negotiate every year. Sadly, among those that do negotiate, the vast majority, they settle with the first agreements, which is what you don't want to do. You think about when you bought a car, a house, or when you were getting ready to propose to your current spouse, it took time, right? There were a lot of due diligence items that needed to be put together for you to sort of win the other party over, right? You have to treat this the same way from other standard negotiations to the dating game, right? We have to take time. We have to work through things methodically. We have to do our research. And truly, we have to find a win-win, because it's not just us that we're asking for a fee increase for. It's our team members supporting those, you know, the wages that are being asked for today, but also helping the patients. It's so sad that you see a lot of insurance carriers on the new CDT codes that are coming from the American Dental Association. Just about every insurance carrier is saying, oh yeah, this is a new code. That's great. It's for Botox. Wonderful. Yeah, we're only going to pay $17 for that. Or another new code that they're going to say, oh, this is a great code. In addition to this other procedure that has been billed to us many times, we're just going to not allow that. And we're not going to allow you, if you're an in-network provider, to collect on that money, you know? And so we have to be careful as it pertains to contract language with insurance carriers is that, you know, don't just negotiate. Never settle for the first fees. Always go through the process thoroughly. Go through at least 5 to 7 counteroffers or even more, right? But always make sure to strike out contract language that is most certainly very harmful to your practice. Now, I want to end with, I get questions all the time. If DSOs are able to get higher negotiated fees, why can't I do that as a solo practitioner? The crux of the argument is that, and no offense to the doctors that are on here today, and whatever your age level is, this is just opinions that I'm going to convey to you that I'm hearing from doctors. So a doctor that's been in a community for 30 to 40 years, the DSO would build up shop right next to them and gobble up a lot of the patients, right? And negotiate fees at a higher rate. So that practice is getting more. But when you look at the average age level of the doctors in that DSO, again, don't be offended at me. This is opinion from the older doctors. Is they're contacting the insurance carriers and saying, I'm getting second opinions from my own patients that are going to this new practice. And what's alarming to me as a doctor that's been here for 30 to 40 years is that my reimbursements, well, I should say their reimbursements based upon what the patients have brought to me. I didn't ask for this. They just brought it to me. I'm getting paid 30% less. And when I look at who's rendering treatment, I have 30 more years of experience. So what gives? You know, why is there this huge discrepancy in an older doctor not being compensated at the right rate, well, at a lower range of fees than somebody that's much less in terms of years of experience? Now, I hear that all the time. The reality is that you can use that as leverage to negotiate with insurance. But the part that you have to be careful with is that you cannot go out to other practices to obtain EOBs or fee schedule data. And you can. It is considered inappropriate, borderline illegal. But where it becomes truly illegal is if you use that data to negotiate with insurance, because that's considered a conspiracy to raise fees. Even though you might be in the right, saying, I want some fairness here, always represented as, I didn't seek out that information. The patients brought it to me. I didn't save it. I didn't store it, but I memorized the numbers. You know, they're baked into my brain. So now you have to answer as an insurance carrier, why are you being sort of discriminatory against me in terms of these fee schedules? And Aaron, I'm going to wrap up here in a second. But that's the whole point is, you know, when we go through the negotiating process, if you are practicing near other large group practices that usually have a higher percentage of fee increases compared to solo practitioners, pay attention to that data and use it in a meaningful way to negotiate effectively with these insurance carriers. Shelley, I'm going to yield the mic back to you. That is my part for today.
Thank you so much, Ben. It's kind of hair raising, isn't it?
Ben knows so much.
Totally.
I was going to
He
say,
does. Yes, my goodness.
Yeah.
Thank you so much, Ben. Hi, Naren. How are you? I think we might have Lila with us. Are you here, Lila?
Yes.
Oops. Yes, I am.
There you are. Hello, Lila. So I want everybody to know how special it is that Lila's with us. Lila is super busy and she spends her time every day helping practices drop PPOs, helping practices grow, acquire new patients. And it's almost impossible to nail down a little bit of time in her calendar to get her to come join us. So normally, Naren would be giving us a large presentation, but today, because we have Lila, we thought we would do a Q&A with the questions that we always get in sessions and questions that we have from people. And they really tie into the subject that we were originally going to talk about, which is 4 common mistakes dental practices make and how to overcome them. So I'm really excited to have both of you here today. Welcome. Good to see you. And I think that Ben might still be sharing his screen there. If you want to stop, you're totally cool to do that, Ben. Thank you very, very much. Let me see if I can actually, 1 sec, I might be able to change that if he's run away. So Lila, welcome.
Sorry.
There we go.
I disabled it.
No, don't be sorry at all. Don't be sorry at all. Hi, Naren. Hi, Lila. It's good to see you.
Hi.
I work with you. This is terrific. Every once in a while, I get to jump in a meeting with Lila, and Naren is also super busy. So it's nice to be here with you guys today. You want to dive right in?
Yeah, so
Sound
let's
good?
just talk about the topic. And I know, Shelley, you have some questions for both me and Laila. So
Yep.
we'll go through them. The topic is 4 common mistakes dental practices make and how to overcome them. I'm Naren. I'm the founder of Equa Marketing. Obviously, I'm also, like I said during the introductory remarks, I'm also one of the people, along with Ben, who started the Insurance Untangled community, the podcast, the events, etc. So I do a lot of things, having been helping dental practices for 18 years. And that's me. Laila?
I've been with Equa a very long time. Going on a decade and a half. I've lost count as to exactly how many years. When you have fun, it doesn't matter. I've done a little bit of everything. I started off in content, which gave me a very good foundation for understanding dental and what dentists do. I moved into customer service, helping our clients, which again gave me a insight into another aspect. And then I moved into onboarding, helping new clients develop their plans, how we're going to get them there, and understanding your pain points, which, gosh, a lot of pain points.
And I believe that meetings that might be booked for Equa are going to happen with either you or me, and we're guaranteeing that, right? One of the two of us, and if possible, both of us. We'd love to. Nothing more that Laila and I love than to get together and sit down and talk dental. And I know that sounds insane, but it's 100% true. Naren, let's start off with the questions. What are the 4 marketing mistakes that dental practices make, in your opinion? You've been doing this a while.
Yeah. I noticed a question from a participant about like how to book a meeting. So maybe the team can include.
Absolutely. Sure.
Link.
Yeah. If you guys want to pop that in, that would be great.
Yeah. So just to kind of give you some background, the meeting that we're referring to is what we call a marketing strategy meeting. So if you have specific questions on, okay, my marketing is not where it needs to be, how do I get there? Like they are good at coming up with a strategy for you. So that's what it is. It's our gift. And anyway, so the link is there, I believe, so you can book it. So let me answer your question, Shelley. What are the 4 biggest mistakes? And then we can go through them. The first one is, giving up control of your own destiny, right? So when you sign up for a PPO plan, and let's say you are infested with them, meaning all your patients or 80% of your patients are PPO patients, you're giving up control of your own destiny, right? Because at the end of the day, your practice is a function of how many patients you have and how much you make per that patient, right? It's that simple. The minute these patients, let's say you have 1,000, and let's say a large number of them are PPO patients, the minute that happens, you are giving up your control. Why? Because who sets the fees? Not you. It's a PPO plan.
Yep.
What do the patients ask? Is it covered by insurance? So if it's not covered by insurance and they need lots of other work, you can't do it. Why? Because it's not covered by insurance. So you're putting imagine, I've seen those Hannibal Lecter movies, and they put him on a straight jacket, right? Where he can't even move because it's so dangerous. Like the insurance company is putting you in that straight jacket where you really have no control of your future, your goals. And as you know, the costs keep going up every year, especially after COVID. Things are 50% more expensive today. But is your PPO reimbursements up 50%? They're not. So they're really tightening that jacket too. So the biggest mistake is being too reliant on PPO plans to drive new patients and where the existing patients come from. So that's the first mistake. The second mistake is, not really understanding paid ads. So we all think, oh, we need more patients, we run some ads. But sometimes if you start really counting exactly how many of those people become new patients, you might be spending $500, $600, $700 a new patient. What I mean by that is 2 problems, right? One is paid ads get more and more expensive every year. Why? Google or social media companies, they have to make their investors happy, and the global population is shrinking. So how do they make the investors happy? They charge you a little bit more. They charge you a little bit more. They charge you a little bit more. So that's one force working against you where your cost keeps going up. The second thing is people don't trust ads. So most of those people who call from ads, they'll only give you 15 seconds on your web page. If they come from a CEO, they're giving you 90 seconds. Why? With a CEO, they trust you. With ads, they don't. And if they're coming from social media ads, they're only giving you 5 seconds. So on one hand, you need a lot more people who are very expensive to make up one quality person who finds you organically. Second, we do call tracking and we know how many of them actually book. The ads patients are 1/3 or half as likely to book an appointment and then show up. Why? Because they don't trust you. So they're thinking, what's the catch? So first reason they're like, oh, maybe I'm not feeling up to it. They don't show up. So your no-show rate goes down, your booking rate goes down. So really like spending too much money on ads and relying on ads, which can be super expensive and really ineffective if you don't know what you're doing.
It's the shotgun approach. An ad is a shotgun approach. The two
Yeah.
of you may not be looking for dental services today. I put an ad out. Maybe you are, maybe you aren't. If I'm organic, I know 100%, Naren, that you typed in something that I serve and I have come up in front of you. Therefore, the people that are going to click on that ad are already my target audience. It makes a massive difference.
100%. The other two things are like neglecting SEO. We'll get into more details, and local marketing. Local marketing meaning you're showing up on Google Maps.
Yep.
And the last mistake is, ignoring reviews, Google reviews. So those are the 4 biggest mistakes based on my 18 years of experience, and especially in 2025 that people are making.
Yeah, thank you very much. Lila, do you have anything that you want to add to that?
I would say not monitoring your website, making sure accountability.
Yeah.
I see a lot of websites that are not being properly maintained.
Yeah.
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 Well, let me ask you this. Is your website reflective of who you are today?
Right.
I actually recently had a meeting with an office and their website had not been touched in 6 years. One of the doctors said, well, I kind of look like doctor from 6 years ago. So a lot of the patients call me by her name. So make sure it's reflective of you today. So
we talked Lila to that absolutely beautiful lady the other day, and her personality was radiant. You couldn't help but want to go in her office, and her website absolutely did not convey any of that at all. It was just a very sterile, plain space that hadn't been updated, no real content, things like that. I'm very, very happy that we're going to help her out with that.
Another office was very surgical, and their website promoted them as cosmetic. They did some cosmetics, but it was surgical was their focus. So is it reflective of your focus, who you are and who you want to portray? You're not going to get your right patients if your patients don't know who you are.
And I think that if I want to add, if I was going to add a marketing mistake that I think people make, it's not assigning a budget to it, not having any marketing budget at all. You have to have something if you're going to appear today in where you're going to be. The old ways, and I mean old ways, that we used to be able to do things don't exist anymore. And when we have something like Lila, if I say to you, I went and saw Dr. Naren and he was the best doctor that I ever had and he was absolutely fantastic, what's the first thing you're going to do?
I ask Google.
Yeah.
We ask Google everything.
You're going to verify your best friend's information on Google, right? You're going to make sure that all the reviews are there. You're going to make sure that
we fact check our friends. If somebody tells us an interesting fact, really? Huh? Oh, you're telling me the truth.
Exactly.
You're ringing off your phone, but I've got to read it off my phone too.
So let's talk a little bit about relying on PPO plans too much. Okay, this is another one of the questions. We touched on it a little bit, but let's rely a little bit more on that, and let's talk about PPO as a marketing tool and that aspect of it, which was touched on earlier today. Can we share more about why it's a problem, Naren? Let's start with you.
Yeah. So
terrific.
Absolutely. So let's say you have a PPO patient, you collect $1,100 from the insurance company, you do all the dentistry you can. You probably have to do like $1,500, $1,600 worth of dentistry to collect that $1,100. Why? They control your fees, so you're charging less than what you need to based on your qualifications, your experience, your technology. And also, even that, they don't pay you the full fee. They pay you only partial, depending on the are you a premier or regular, et cetera, et cetera. So pretty much you're doing $1,500 worth of dentistry or $1,600 worth of dentistry to collect $1,100, right? So that's one problem. Now that patient is with you for 10 years. So every year, let's say that continues. So every year, extra $500 worth of dentistry you do, you don't get to collect. So you're repeating. And now 10 times 500 is 5,000. So the cost of acquiring the patient was $5,000. The question you have to ask yourself is, are you in the business of giving your insurance company $5,000 per patient or not? If you're not, then hey, stop doing it. So like I even know stories where some doctors are losing money, especially on hygiene, depending on the state, where when you calculate your cost for your employee, et cetera, your rent, et cetera, you might as well not see the patient than lose money, right? So I think when you are stuck in this situation, when you have so many of these PPO plans and most of your patients are PPO, you're spending thousands of dollars to acquire a new patient. Now imagine, especially for example with SEO, you're spending $60 to acquire a new patient. PPO $5,000.
It's the only, and I mean this, it's the only industry I've ever seen where your acquisition cost for a patient never ends.
Yeah, you just keep
It
paying
never ends, right?
for
So it's
lifetime.
not that I paid $300 to acquire you today, Naren. It's that I'm paying $300 every single time you come to see me.
Exactly, exactly.
Yeah,
And the other thing is the thing that 99% of my doctors hate is it covered by insurance? So these patients, they are trained, they could be earning $500,000. I know there's an example, this woman at Google, he was in California, she makes more than $500,000. She's a senior VP, she makes gobbles of money. Even her question is it covered? Because they think if it's not covered, the doctor is trying to sell me something. So these patients come with that mindset of, is it covered? Is it covered? So you're doing, tooth dentistry, you're fixing this, fixing that, versus beautiful smiles, versus restoring health. So a lot of times, I think the bigger motivation for doctors is they want to enjoy their life. They don't want to be just, running, doing free dentistry, which the customer never pays for, therefore they don't appreciate. They want to do the big cases, get paid 20 grand. And the people are like, man, you changed my life. Or doctor, you changed my life. That's what they want. So that's something I really think we should lean into. So what's the answer? Drop the worst PPO plan. Replace
yes.
that person with, Google patient. Because remember, even the PPO people, what is the first question they ask when they call your office? Do you take my insurance? Which means they're not going to the insurance website to call you. They're going to Google to find out that you have wonderful reviews and calling you. But now they want you to put you on this, $500 off for the rest of my life package where you keep doing extra dentistry, which nobody pays for.
Lila has I'm going to put you on the spot completely, Lila, and you can beat me up later on. Good thing we're on the opposite sides of the continent. But Lila has an absolutely magic way of answering the phone for that, right? You're out of network. Lila, hi, my name's Shelley. Do you take Delta?
Hi, Shelley. It's wonderful to talk to you today. We have a lot of patients in our practice that has Delta insurance. We're not in network, but we will help you make the most of your benefits. You are more than welcome in our practice.
Absolutely. So is that going to win over every single person that calls? No, but is that going to win over the patient that you're trying to attract into your office? Absolutely, it is going to. And Lila, can you talk?
And imagine 80% of those patients Lila is able to close because she just mastered it, right?
Yeah.
Now you're saving that $500 you're giving Delta in the form of a write-off.
Yeah, now it's yours.
Yes. It's $5,000. Lila just made you $5,000 versus, let's assume you are on network, with that PPO plan that doesn't pay you well. You're giving them $500 every year as a marketing fee to that company.
Every time the patient comes in, you're giving them money, right?
When it comes to those insurance patients, an insurance patient falls in two categories. The ones that see insurance as an actual benefit. Oh, it covers this much of my crown. Cool. Mm-hmm. I'm still getting that crown. I'm still getting this procedure. The ones that insurance drives their life. The ones that are not going to respond to that phone script are the ones insurance drives their life. And you're the ones that are, yay, bye-bye. The others are welcome in your practice because they will use insurance as what it is. A benefit that helps them cover some of the costs, and they don't care whether Delta says Invisalign's not covered. I don't care. I want Invisalign. I want that implant. I don't want a bridge that's going to make you grind down 2 healthy teeth.
I talked to front desk a little while ago that said that the power that she got back, she felt incredible because they were able to start to filter their patients. And Lila, you can do that with your website too, right? So it all carries over. So what we're trying to tell you here is that it's all part of something. It's all part of your branding. It's all part of what you do. So you bring the patient in through the website. You build up trust with the website, right? So if we can get 100 people to come to your website and they're clicking and that's not building trust to get them to call the office, it's a whole ingredient. And that trust that they're building is also the reason that they're going to book out of network with you.
And it kind of goes back to the point I made earlier about your website needs to reflect who you are. Precisely. Because that's part of the trust. When they see, oh, that's what Dr. Naren looks like, that's what his philosophy is, that's what he believes. He believes in preserving
Naren talking about his philosophy on your website. Gosh, you use video. Lila knows how I feel about video on your website. It's where you need to be.
Yes, as an element to Shelley's SEO cake.
Oh, yeah. We're not going to give people the cake unless they book a meeting.
Okay. There's a surprise recipe, but only if you...
Let me ask you. Go ahead. So I think...
go ahead, Naren, please.
Yeah. I was going to say, so just from a strategic perspective, right? Mm-hmm. Start getting control of your marketing. And which means find the best way to get patients at the lowest possible fee. And I think SEO is the best.
Yes.
Next comes Google Ads, which is 5 times more expensive based on the trust issue we talked about, where they don't book and then they don't show up, and they don't, even when they're on your page, they don't spend too much time because they don't trust you. And then the next best is Google, social media ads. So that's 2 times more expensive than Google Ads. And then finally is PPO plan. So pretty obvious, right? Start dropping the worst PPO plan one at a time. Replace them with, ideally SEO / Google Maps or local patients. And then once you are getting enough, drop the next one, and then keep going, keep going, keep going. Like I had a client who was working 4.5 days, making $650 a year because it's all PPO. I'm dating myself 10 years ago. And then within 2 to 3 years, she went to $1.3 million, and she was working 3.5 days. What did she do? She dropped pretty much every plan except one. And she now replaced them with these full fee paying big case patients who are, Invisalign, she was very qualified and very skilled, different things she was able to do, like implants and so forth. So she just worked less, is making double the money. So 1 day less and, 1.3 million. I think everyone can do this. So, I think, remember, insurance is never, ever, they didn't do this in the last 50 years. They're not going to do it starting now. Never going to pay you more and more and more, even to keep up with inflation. So you really need to kind of go on the offense, take control. Now, to do that, I think you need to be one of the top websites on Google when it comes to SEO. And Google makes so much money from ads, so they don't want to make it easy for you. So typically 5% of you will have the privilege of getting all the traffic, or less than 5%, from Google for free. So the 95% will give Google Ads money, which is what drives their business model. The second thing is Google reviews. So because remember, people are checking you out on Google, and even the insurance patients, that's how they're calling you, based on checking you out on Google. Try to get 10 reviews a month. So that would be my tips, right? Like,
easy. Yes, absolutely.
Get into the top 5%, and then, try to get 10 reviews a month. Those two things. If you're doing that, and then start dropping one PPO plan at a time, starting with the worst, you might keep one or two of the best ones. They're paying you the best, and, maybe, for lots of strategic reasons, but everything else, just get rid of them eventually.
I've talked to a lot of offices that will say, oh, if I drop insurances, I'm going to lose most of my patients. Well, there's two things to consider. A, if you are going to lose all of your patients because you are dropping your insurances, you must not be a very good office. But those few patients you're going to keep most of your patients, because I'm going to assume everybody here is an awesome office. The patients you do lose are the ones you're not going to cry about. They're the ones that let insurance dictate, and they're the ones that's making you run from filling to filling to filling and not be able to do the dentistry that you enjoy.
Yeah, even when you drop the PPO plans, you're still going to file the claims. You're still going to help them get the most out of their benefits, right? And again, you're not dropping every plan. You're just dropping one plan, the worst one. And then, so it doesn't kill you. And if it goes well, and hey, so this particular lady I was talking about, she was getting a lot of new patients coming through Google, through SEO and what the stuff we were doing. And she's like, I don't want to add a 5th day or a 6th day to my schedule. So she's like, what do I do? Oh, let me try getting rid of some of the patients where I don't make any money. And she just kept going on and on and on.
I'm going to share now. If you guys want to, you can scan this UPC code. You can book a meeting with us. Myself or Lila will attend, and we're really going to try our best for both of us to attend. And it's kind of self-serving because we really enjoy working together. So that's a lot of fun. Naren, we got a question in, and I'm going to ask you this one because it's a fantastic one. And Lila and I get asked this on a daily basis. What does EQUA stand for?
Yeah, EQUA stands for being in the moment. So it's a Indian word, native Indian word. And this particular Olympian, she, after winning a bronze medal, she talked about how, this person talked about, like, when you are competing, forget about everything else. Forget about the cheering crowd. Forget about the hours you put in, all the parents and the uncles and the aunts and the instructors who put so much time and effort to support you. Just get rid of all those expectations. Just be in the moment. That's what EQUA means. Now, I'm going to brag on both Shelly and Lila. And Lila, of course, has been doing it for at least 7-8 years. She has been with us for 15 years. You're going to learn a ton. I just gave you high-level strategy. I think you want a specific strategy on, like, where are you today when it comes to attracting patients, and then how do you get into that top 5%? How do you dominate so that way you have an unfair advantage? Unfortunately, we can't help everyone, but we can help 5% of our doctors, or less than 5%, because we can help you dominate. We can help you be in the top, which means you're getting more and more $60, $70 high quality patients who are looking for high value, including veneers, Invisalign, etc. And then you start dropping the PPO plans because you don't want to work harder. You want to get rid of the ones who make you the least money and attract more of the ones. Of course, you have to get the Google reviews. Of course, you have to be a great practice. If you're a crappy practice with 3.4 stars, I don't think you should call us. I'm being very blunt because I am not here to teach you how to be a good dentist. That's not our superpower. That's not our strength. But if you are a good dentist who has those Google reviews and 4 stars, 4.5 stars, and you want to become even better at attracting those awesome patients who appreciate you, pay you full fee, then hey, we really can help you.
I am going to add one thing to that. If you bought a practice and inherited reviews with 3.4 stars, you can still call us and we will help you see what we can do.
And Lila and I have some homework for everybody. This is something we actually give to everybody that we meet with regularly. If you're looking at your site and you've got reviews that are more than, I'm going to call it 3 weeks old, but definitely a month old. If you're running something like you've been around for 3 or 4 years and you look and you have 15 reviews, and even if you don't, Lila and I want you to start tomorrow, start small, get 1 review a week, start adding it. This accumulates. It's not something that ever dies down. You don't get to say, oh, great, we've got 500 reviews. We're done. Are we done, Lila?
You're never done because what happens? You got 500 reviews, you stop 6 months, and now somebody's looking, oh, wow, that must have been an awesome office. Must not be anymore.
Right. Well, that's exactly what people think, right? When I tell you to go somewhere and you go and look, that's exactly what you're looking for. You're looking for social proof. That's exactly what you're looking for. We're at time and it's time for a break. You guys have been absolutely incredible. I hope we get to do this again. It's a lot of fun to do it this way. Thank you, Naren. Thank you so much, Lila, for coming and
joining. I've got to drop off. I'm heading for a meeting, but please book a meeting. Much, Lila. I look forward to talking to everybody.
Take care. You're a busy lady. Thank you very much.
Any questions, send it to us. So I think the best thing is to just have a chat. You will learn it. You will get all your answers. Thanks, everyone.
Perfect. Thank you very, very much, everyone. Hi, Rebecca. Oh, you're on mute. No worries. I probably jumped in and made you jump because it was so quiet before.
Now can you hear me?
Yes, I can. How's your day going?
Great. Thank you so much.
Awesome. Hi, Carla. Hi, Leah. How are you guys doing today?
Good. Thank you.
Hi.
I'm excited to be chatting. We'll give a couple of seconds. We'll just chit chat a little bit on the first day of spring. We were talking about that in the first panel. And just let people come back a little bit because I started the break a touch late. How are you guys doing today?
Great.
I was saying that I got a text from a friend last night that said, hey, it's the first day of spring. I have to, like, my mood just went off the charts immediately.
I know. I've been praying for spring for the last month.
Exactly. Right. This is a year that I didn't go south and I regret it big time. Actually, if every year you don't go south, you regret it. Right.
Yeah.
Absolutely.
It hasn't been great in the South either. I'm in North Carolina. It's been very cold.
That is fair.
Yeah, so that's why I've been praying for spring.
I hear you. Usually we're in the Caribbean or Mexico, but yes, it's been quite interesting. Absolutely across the states.
I do not want to make anyone jealous. In about 6 hours, we're on a flight to Cancun.
No, not jealous at all. Not jealous at all.
No. Okay. Good.
You're right near my favorite, which is Cozumel. I love going to Cozumel. Yeah.
We have a condo down in Playa. So
beautiful. You're right. You're a little boat ride away.
We are. We're actually going to take a little boat ride over to Cozumel because we love going over there too. So
sunshine sounds.
So sorry. I'll bring the sunshine back.
I was going to say.
Do that. I've got a little list. I'm not going to say tequila's on it. I'm not going to say it's not.
No judgment.
Okay, guys.
No judgment.
Happy Friday, everybody. Welcome, everybody. Today, we're talking about the business panel this afternoon is key growth drivers. Growth. This is the second part. I worked in EMR and practice management software, and that drives growth. And that's something that I've been working on. And of course, marketing drives growth. So this is a really exciting subject for me. I'm very, very happy to be here. I love to start by getting you guys to introduce yourselves and tell us a little bit, because if I read stuff, it's going to be boring as all heck. But Rebecca, I think you can tell us about yourself much better than I ever could.
Thanks, Shelley. You're so sweet. I'm Rebecca Herring. I've been in dentistry for, I'll just say since birth. My dad was a dentist, and I love being here.
Definitely since birth. Yes.
Since birth. Trust me, because way back then we were doing all the marketing that you talk about, pumping the lotion into the bottles and putting the labels on. We had to fold the letters before they went out in the mail.
Did you have the
And,
dental one right system with the big, huge clunking things that went over?
No, we weren't even, we just sat at the table as a family and would fold them and stick
That's
them in the
amazing.
envelopes, lick them, and then seal them. And if you don't know this, back then it was 33 calories every time you licked that envelope. So,
Well, there has to be some kind of energy expended.
There
licking an
does.
envelope.
It's dedication, right? Right to our dad. And I do give a lot of kudos to my dad and in his teachings to me as a person as far as compassionate care and giving back to those. And so it's kind of what drove me into my business in transformational dental coaching and into my new role with Rocket Station, which is about virtual assistants and bringing them in and implementing them into your teams to not only support the team, but to help grow your practice. And that's what I did in my last role. And I'm happy to share all of those awesome experiences with our listeners today.
Thank you and welcome. And thank you so much for joining us today. Carla, would you tell us a little bit about yourself, please?
Yeah, so I'm Carla Santiago. I've been in dentistry for a little bit. Oh.
I got it backwards. Okay, there we go. Sorry about that.
Yeah, you're fine. I've been in dentistry for a little bit over 10 years. I was in healthcare before. My background is in dental operations and dental procurement. Dental procurement is what I've been doing, mostly focused on the last 5 years. I've worked in all areas of the industry. I worked in education, for a dental school. I worked in the nonprofit area, and then I worked in the DSO space. I also do dental consulting, mostly focused for procurement for dental support organizations, and then I do a lot of vendor relations. So happy to be here. Thank you for the invitation. I'm looking forward to sharing my experience.
You definitely run the gamut. That I think that covers every single type that we've got. Thank you. Welcome, Carla. And Leah, can you tell us a little bit about you?
Yes. Good afternoon now. My name is Leah Martin. I am on the West Coast. Most of my clients are out here. My background is I have worked in different dental practices early on while I was in college as a dental assistant, then office management, helped start some practices. And then for the past 20 years, I've been working as a coach consultant for my company, Martin Practice Management. And my area of expertise is kind of taking a lot of these different tools we've talked about today and really customizing systems, coaching, verbiage, and helping integrate a lot of these things successfully into practices. And so that's my focus as I start with chatting with the doctor and team about what the goal and the vision is, whether that's revenue, decreasing overhead. Usually those things go hand in hand, and how I can help the team and the doctor reach their goals.
Amazing. Thank you so much. Okay, so we're going to kick off. Our format is a little bit like it was this morning. We've got a bunch of questions here that have been submitted. I think you guys have seen the questions, but we'll try and take it off into places that it naturally goes. The questions are divided between you guys, but everybody chip in because, as I said this morning, we've got so much fantastic experience and a great learning opportunity here. And I am going to, one second, get my questions up. I'm going to start with Rebecca. And Rebecca, what are some ways that practice owners can support business growth? This is really good because this is such a problem right now during staff shortages. Big problem right now, especially in hygiene.
It really is a concern for a lot of dental practices in trying to find the right candidate that fits what they're looking for their practice.
Yeah.
So this really does go back to a special niche with my coaching, which is finding a virtual team member that can support them. This is really great when you're looking for someone maybe specifically to take some tasks off of that front desk team. If you are missing a team member while you're doing that search for maybe a replacement for that front desk team member, insurance verification, phone support, some of the things that tend to take away the time from someone at the front desk who really needs to focus on the patients that are in the office. Yeah. Insurance verification, as we all know, is very time consuming. It's not something that someone has to be in the practice physically to be able to do. Yeah. So while you're doing that search for a practice new team member, You can work with a virtual offshore team member who can do these things for you during your office hours and put in the insurance information into your practice management system. They can reach out, they can do confirmations, they can work your schedule, they can answer the phones for you. These are some of the really easy things, which supports your shortage in the practice at the time. At the same time, they can help grow your practice by reaching out to some of your patients that might be on a ASAP list when someone cancels last minute, to keep that production high in the practice by not allowing that open chair time to exist in the practice.
Yeah, that makes a lot of sense. It's such a scary thing to walk through a practice and see people idle.
Yes, no one wants that.
And it frustrates people to be in that atmosphere. Nobody wants to go to work and just sit there and, okay, there's 3 or 4 people. I'm not one of them, but nobody wants to do that. We're there to work, and it's frustrating to not. So yeah, it's very important to fill those gaps for sure. We're gonna change subjects slightly here. So that's kind of the format when you have questions that are from audiences, that it kind of swings back and forth. So Leah, I wanted to ask, we're gonna go by a little bit insurance, and we talked about this morning a little bit, but it really bears driving home, especially as we come to a close on Q1 and we're trying to sharpen our pencils and be better for Q2. What dental services might my practice be overlooking that are covered by insurance?
A great question. And I think we've had a lot of discussion about all the services and things that insurance covers, which is great. And I always want my teams and docs to utilize all the patient's dental benefits as much as possible. I was in a practice a couple weeks ago that was a new practice. And one of the things that I was noticing was the dentist had multiple patients that were in network with Delta Dental. And for example, they were billing the patient for 6 unit of veneers, and they were billing the patient their contracted fee. And so I think it's really important for dentists to know, as we talked about earlier, that these are services that we can bill as non-covered services, as long as we educate the patients about those things up front. So, for example, twofold. One, we need to make sure we're communicating really well in office. This is an aesthetic elective procedure. It's not covered by your dental insurance carrier. I know every state is a little bit different, and Ben can speak really well about that. But I think it's really important that patients do understand that there are elective services that aren't billed to insurance, and that we can utilize our full fee for service. And then making sure we just have documentation of that with patients.
And making sure that conversation starts when the patient calls to book into your office. You want to be having that carrying. We talked about this sort of all day. Having that carry right through from, let's talk, Equa does websites, having it carry it through from Equa's website, right through to the person who answers the phone, right through to what the hygienist is saying when you're in chair. It's really important, in my view, to keep that consistent all the way across when you're talking to the patient, so that message is consistently there.
Yes. And I really like the verbiage that you guys spoke about earlier. That's a big piece of what we as coaches do, is really helping to get those teams to use the verbiage to get those patients in the door from that first initial phone call that you're talking about, because they're making investments, in those marketing calls that are getting driven in by the external marketing that they're spending.
And Lila is so good at that, because we record the calls, and there's a reason to record the calls. It's so that you know what's happening at the front desk. It's not there to be a penalty. It's there so that you can coach somebody on how to talk about these things, how to talk about the services that aren't covered, how to talk about if you're not in network. So that's really, really beneficial. And I know all 3 ladies here can help you with that, with your office, right? Answering the phone. Now, Carla, we're going to switch slightly again. We're going to talk about overhead, and we're going to see what are ways to reduce cost and overhead in your practice and add value to the bottom line.
Yeah, I think anytime people hear the word overhead, they're like, oh my gosh, it's all about expenses, right? So a lot of people, in my line of work, some people, when they're in operations, they focus a lot on the top line. Yep. And so we in procurement specifically focus more on the bottom line, right? So we want to look for ways where we can reduce that overhead, specifically when it comes to dental supplies and lab cost of aligners, and, capital equipment, invested equipment. To me, first of all, pre-pandemic, supplies went up, post-pandemic supplies went up about 7 to 10% of revenue, and labs went up all the way to 13%. So in an ideal world, the combination of both should be no more than 14%. I think that right now, a lot of, practices are aiming for a 4% when they're in a general practice, general practice services, just only on supplies. And then, no more than, 6 to 7% when it comes to labs. A couple of things that practices can focus on. First of all, when it comes to supplies, is inventory management. I always say that that's the first step when it comes to supplies. I always give the example of, like, before you go grocery shopping when you're at home, you first check what you have in your cabinets, in your pantry, right, in your freezer. You want to make sure that you know what you have before you even go out and buy anything else, right? And when you do that grocery shopping, you want to make sure, okay, I want to have enough for like 2 weeks, for 3 weeks, for a month, right? So it's the same concept when you are in a dental practice. You need to think about what services you're going to offer, what your schedule is going to look like for the next couple of weeks, and do I have enough inventory in hand, to operate those and provide care for that.
So you're not a fan, Carla, of the rep going into the stock room, filling it out, coming out and signing a piece of paper and losing all control completely of what's in your room?
No, no.
Neither am I. Hey,
No,
what are you doing back there all alone?
No, because one of the things that you want to avoid the most is disrupting patient care, and canceling appointments because you don't have what you need to provide the care, right? So inventory management is super important, and it actually, not only from an operational perspective, but financially as well, because you avoid expired supplies, which is a loss of money. You avoid duplication or excess, so all that reduces your overhead. When it comes to labs, the industry has moved a lot into technology. So there's a lot of practices going into digital dentistry. Which, even though there's an initial investment, a high initial investment, because the equipment needed is not cheap, right? It's not a low price, but a lot of practices are looking into producing, that production, keeping it in-house and reducing those costs instead of sending it to an outside lab and paying, a higher overhead because of that.
Well, I've heard a lot of people say that digital impression equipment will pay for itself before a CEREC.
Yeah. And honestly, if you look at the ROI, depending on the production that you're doing, you can get that back in like 6, to 12 months, even, if you're doing it right. There's always pros and cons to everything. So, you obviously, if you do it in-house, you have to have somebody that knows how to design, how to produce, and, and all these things. But that's another way of, kind of reducing the overcost. I would believe you're never going to have not the use of outside labs, but you can definitely reduce that percentage. And then from a capital equipment standpoint, as you know, obviously interest rates started reducing, not much. There's still high interest. The loaning money and like having that money for people are being a lot more strategic into buying equipment and investing in equipment than they were before. So I would suggest for, capital equipment, and I'm talking about, a lot of people define capital equipment differently because they have different thresholds, but whatever your definition of that is, I would say keeping an inventory of it, tracking their maintenance, tracking their, the life that they have, and providing really good, preventive maintenance, and then keeping track of like what projected replacements are coming up, so that instead of being a reactive approach where somebody's equipment went down and now you're having to spend, 50 grand out of nowhere, then keeping up with that inventory, providing the maintenance it needs, and a list of, what do I need to replace in 1 year, 2 years, 3 years. So that's just a couple of things. Obviously, there's a lot more in detail that goes into each one, but yeah.
And of course, keeping an eye on those ongoing supplies that go with that equipment, because there's a whole bunch of stuff that go with it you might not be thinking of in that first initial way. Yeah. That's going to be a recurring expense.
And that goes in the investment, which a lot of people, don't think about. Yeah.
Oh, my annual cost is what on top of my lease payment? Ouch. Right? Yeah, absolutely. Let's go back to talking about having temp workers working for us, Rebecca. How would we identify, I'm busy, I'm run off my feet, I don't know what I'm going to do anymore. How do I know when it's time to reach out to someone like you and say, okay, I'm going to need some help. I need somebody coming in virtually and helping me?
That's a great question. I think a lot of people sometimes are on the fence wondering if that's what they need to do. So
Yeah.
great question to ask. A lot of times our front desk team members are exhausted and they're burnt out. And a lot of times what we find happens is that they have someone at the front desk who has left, whether that's, spouse got transferred, they're moving, they're having a baby, whatever it may be. And what ends up happening is those responsibilities get put onto somebody else.
Yep.
And they say, well, we're looking for somebody. Can you take on this, this, and this?
Right. Can you take on talking to people about and getting them to pay their bills and doing insurance and answering the phone with a bright smiley face so that we can get it booked? Yeah.
Smiling every time. And as team members, of course, we say, of course, I'm happy to help and I'll take on what I can, right, while we're looking for somebody. And that process of looking for somebody takes longer than we expect.
And it should take a while. It should take a while.
It should, yes, it should. As you find the right team member.
Yeah.
What happens then, of course, is that person gets really exhausted and tired and burnt out. Yeah. So what I usually suggest to dentists and office managers is to ask your front desk team, if you could take 2 or 3 things off your plate right now, what would it be? Yeah. And if they are things that are repetitive administrative tasks, like insurance verifications, responding to emails, trying to do those new patient paperwork, following up on claims that are outstanding, some of those kind of things that are just really repetitive things that are just taking them too much time. It's time to look for somebody that can support you remotely.
I think a question that is going through my mind for sure, that I'm sure that listeners must be wondering, is what kind of bursts can I hire? That might not be the right way to put it. What kind of bursts can I hire these people, and what kind of timeframes? Can I do a week? Can I do a month? Am I committed to a year? Like what kind of timeframes are we looking at when we engage somebody that's virtual?
Yeah, I mean, generally you can hire them part-time or you can hire them full-time. When you talk about, earlier when we were talking about, the overhead costs, they're not as expensive as hiring within the United States. They're going to be somewhere. A lot of companies do like a monthly rate. A lot of them will do them hourly. So you're only paying them for the time, just like any other employee that they're working in your practice. Mm-hmm. So you can do a part-time, you can do them full-time. One true benefit that I see in hiring them into a dental practice is a lot of offices aren't open on Fridays.
Right.
And so having someone in your practice that is willing and able to answer your phones on a Friday or even on a Saturday for half a day when they might be emergencies that could wait till Monday, they keep your schedule full and keep that production going while also keeping that overhead of your salary lower.
That makes a lot of sense.
Knowing what the team is feeling overwhelmed with helps them know if they're ready to take some of those tasks and offset them to someone who can help them remotely and take some of that burn off and the stress off of their in-office team.
Thank you very much. Over to Leah. And another slight change in subject. So we're going to go back to insurance a little bit, and we're going to talk about utilizing the appropriate codes for all covered services. And we did go over a little bit of this morning, but it is super important. And as I said, we're sharpening our pencils for Q2. I'd love to know what your tips are on this. This morning, we heard some information about making sure that you're updating those combo codes in your software. That would be an example. What other things should we be doing?
So we have talked a lot about that this morning, and I think this is a good one of codes that we use regularly. And are we maximizing, not only providing the value-added service, but are we maximizing the codes that we could be utilizing to create revenue, but also to give great patient care? Yeah. And so one of the things that I recommend doing is taking 4 bite wings and 2 or 3 PAs. When you're updating the bite wing series, taking the 2 or 3 PAs. One thing to know about that is what they're looking at, because a lot of offices hesitate to take additional x-rays because they're worried about the insurance company converting that to an FMX.
Right.
So really what they're looking at, as long as you're not exceeding the total fee for the combined FMX, so kind of talking about bundling, they won't convert it to an FMX. So one, it allows, I've had several dentists that have, they've caught decay around the gum from taking those anterior photos or x-rays on the upper and the lower. You can do it one of two ways. You can take the 4 bite wings and 2 PAs, because most of the time that won't exceed your FMX.
Yep.
But you can also take the 4 bite wings and 3 PAs, which I like, and just not bill it. Or some offices like to break it down over the cost of the 3 PAs so that they're not exceeding the limit. Obviously, yeah. So that's a great utilization. I think another one that's really important to utilize, and again, this goes along with your standard of care and what are the systems and protocols that you have set up in your office, that's missed, is offering fluoride to every patient. So if we believe in fluoride, we shouldn't just be offering fluoride to the patients who have a dental benefit. And I see this all the time. And what I find is my offices who we get the front desk trained to actually just add it to the patient appointment, it's amazing how that will prompt the hygienist to go ahead and ask the patient. Or in some offices, the front desk is asking it as the patient comes in, and we have a set fee that we charge that's maybe less than what we even bill to insurance. So they'll say, for $30 today, we'll go ahead and do your fluoride varnish. And then they just add that to the appointment so the hygienist knows that that's covered.
It's a little like when you go to get your nails done and you walk out with all the glitz on your nails. You go, how did that happen?
Exactly.
I know.
And I got fluoride. Boom, look at that.
Exactly.
There you go. It's a little bit like that, right? Upsell.
For sure.
And it's a crude way to say it, especially because we're talking about healthcare and dentistry, but it is sort of upselling, but a benefit for the patient at the end of the day.
Right.
And that's what we keep at our heart.
For sure. It's a value added service for the patient, and hopefully prevents decay, so they end up needing less restorative dentistry.
Precisely. Yeah. Good conversation to have. These are good conversations, right? Let's get it before it happens. Yeah. Let's talk back about procurement, Carla. So let's talk about what procurement is. What is procurement, and what is the importance of procurement for the dental practice? That sounds like a simple question, but I know it's not.
Yeah, I think it's funny because in the dental industry, the term procurement is still something that is not necessarily understood or utilized.
Right.
A lot of people just, I would say, reduce it to just purchasing, right? So people think procurement, people think about, well, purchasing supplies, right? So yes, procurement is the acquisition of goods and services, but within the acquiring of those goods and services, there's different things that, are in play. You have data analytics. So, so in procurement, you do have to review data like any other, process or any other area in your organization. You have key performance indicators that you have to track. You also have to do contract negotiations and contract review. It goes into vendor relationships, which is one of the most powerful areas of procurement. And then you also have risk assessment and compliance. So there's like all the things within the umbrella of procurement. And then, yes, purchasing is one of those functions under that. So I would say, like I said, look at procurement as the umbrella, and then purchasing, contract negotiations, compliance, risk assessment, all these are under, that procurement umbrella.
I wanted to pull something out that you mentioned there, that people might not think of applying KPIs to procurement. And I think that's a really smart thing to pull out, because I'll bet dollars to donuts that way more than 50% of the people here are not doing that. Do you want to talk about that a tiny bit?
Yeah, I'm a data geek. I love it. I love data. I love it. I feel like data is my love language. So, so key performance indicators, like I said, they're not only on the operational side, they're also on the finance side, right? So you want to make sure, obviously, you're tracking overhead already. So that by itself is a KPI. So how much, percentage of revenue it's going towards dental supplies, how much is going towards equipment, how much is going towards labs. So right there, you have 3 KPIs, right? You also want to track about like how much percentage of that, or how much money within that percentage is going to each of your vendor relations. And the reason why you want to do that is because you want to know, well, which vendor am I utilizing the most? So with which vendors should I focus my relationships on, right? You also want to track compliance. And when I say compliance, it could be many, many things, right? But looking at it operationally, a lot of offices or even dental support organizations have what we call a supplies formulary, which is a predetermined list of the supplies that are used during care. And what happens is you want to track how many of those actual items you're purchasing, or if you're moving how percentage of items you're buying outside of that. So typically when you have a formulary, you have pre-negotiated pricing. So anything outside of that might not give you the leverage of the negotiations that you have. So you want to track that as well. So yes, KPIs in procurement is very powerful. I have a colleague that says procurement is not sexy, but it is important. So I totally support that. It's
important things are never sexy, right?
right. So it's definitely not like something that people are like, oh my gosh, I want to do procurement. Yes, no, but it is definitely something that is really important, especially because after labor, it's one of the highest percentage in your P&L.
Yeah, for sure.
So you want to make sure that you have control over it, and then you're proactively implementing strategies to reduce it or keep it in a constant.
Speaking of the labor costs and the procurement costs and everything, in my true and strong belief after many years, you need to be sharing some of those percentages with your staff, because the numbers that they see go through, and if you don't ever have those conversations with staff, the conversations you end up having are completely unnecessary. So if you share that information with your staff as you go along, I think you really stand a lot. That's totally off subject, but mentioning it, they need to know that stuff costs money, right?
And I'm a firm believer of like, managers' compensation plans and incentive plans. A lot of them have bonuses based on production. I would even suggest have an incentive based on procurement, on making sure that the percentage keep under the budget and they follow, or they look for ways to save, or, so I would say even in compliance, I used to supervise compliance as well, clinical compliance, same thing. It's like you just give them the incentives to keep those in the numbers that you want them to keep.
Well, for management, you should be incentivizing on patient acquisition costs, on the insurance bills that we're coding. Are we making sure that if we have a virtual assistant, we're spending a whole bunch of like the proper amount of money on it? All of those things should be things that we're incentivizing, not just production. Because if we bring production in and it's $100 and we're spending $50 to get there, let's make that $30 to get there instead. Yeah.
And what Leah mentioned about, the fees and all that, like, that's another thing that I always say, you want to make sure that you review your fees like annually, right? Because
minimum.
And you want to make sure that you compare them to whatever other claims have been submitted in the area that you're at, because labor has gone up, supplies go up, so you want to make sure that you are still covered and not having fees from like 20 years ago versus, the economy of the present.
Exactly. Yeah. You'll have a great patient base, but it's going to be So speaking of virtual assistants, I would really like to know some of the arguments that you get. And I'm positive that you get a lot of them. Yeah. I'm positive you get, oh, I'm going to suggest this. I don't want that. So what are some of those, and what are your responses to those that you get?
This will be fun.
Yeah.
I mean, there's always those that are like, oh, I've just heard it's horrible and I don't want to do it because it involves so much training. And so there's absolutely pros and cons all the way with bringing someone in virtually. So when you are looking at this, I think the biggest concern that people have in bringing in a remote team member is the security, the protection, HIPAA. So absolutely, one of the first things I like to talk about and address with anyone has that concern. So one of the things I think that's important for dental practices, they should be protecting themselves regardless, because whether they're
no matter who you're bringing in the door, right? Yes.
Right? Yes. Anyone that's coming in your practice.
Hey, from practice management, I recommended net nannies on the regular because it's easier it's easier to give than it is to take away, right?
That's right. It is. And so, yes, I do recommend that whether they're working in your practice or outside and remoting in, please make sure that you have all of your ducks in a row to protect your business. Because it isn't just that you have a remote person, a remote team member, right, that's coming in. You have every threat. You have embezzlement.
The vulnerability of a dental office is sky.
That's right. Absolutely. It's everywhere. And it's not just a virtual team member. So one of the things that I do really appreciate is I'm currently working with a company called Rocket Station. And they are a company that has what they call the ISO certification, which is the highest rating that you can have in protection for any business. So they have all the data security and the cybersecurity protection that they have in place. And that's the best recommendation I can make for a business that's looking to bring a remote team member in.
Yeah, it really is. I've got a lot of experience. I'm actually an ISO auditor. So I've got a lot of experience in that. And it's about as good as you get.
It is. The next argument that we find people have is the training side. Remote team members are not plug and play. They are not someone who's going to come in and they're just instantly ready to go. You do have to train them, just like you would anybody else you've hired for your front desk position in your practice.
Each office is supposed to be unique.
Yes, exactly.
Yeah.
They do have, I mean, they are going to know dental terminology and they are going to know your PMS system and they do know those types of things, but it is unique to your practice. And I think that's the one misconception that people have about working with remote team members is they aren't just ready to go. You do have to invest in them.
Right.
But this is where the pro comes in with working with virtual assistants is you won't get someone who will call out because they're sick. And you won't have someone who will just be calling in, I just need a mental health day. They are dedicated, they are loyal, and they are there to stay with you. I think I mentioned in the beginning with my last position working in a dental practice, but this is what we did. We brought in 5 virtual team members and they were completely replaced the front desk. We didn't have anyone. I don't recommend that, everybody. But
saying the occasional patient wants to see a human.
Well, we had our virtual assistant on a screen.
Oh,
So
neat.
there was someone physically there to talk to them.
Oh, that's neat. Yeah.
But and again, this isn't for everybody, but I still love that person there. That's what I would recommend.
I think that's going to play to different demographics in different communities. Right?
Absolutely.
If you're downtown in a major city, it'll go over really well. But if you're, more rural, that's might not swim as well.
Right. Exactly. Yeah. So you have to play to your patient demographic. Absolutely. And honestly, the demographic of your office too. That may not fit the culture at all. Yeah. But it worked well for us and our patient load. But the patients that came in, they loved our virtual assistants. And this is where that pro con comes in. That virtual assistant should be just as much a part of your team as anyone else. Our virtual assistants came to our morning huddle and they joined in our team monthly meetings. And, we played games and we did all the things with them as though they were part of our team. And that's where the difference will come in. Which is where some offices that pro and con was how are they even part of our team if they're not there? Yeah. It's really up to you to make them part of your team. But
I worked remotely for 20 years. I think I'm a part of a team, right? It's not that hard. Yeah.
Yeah. I say I feel very much a part of all my teams with my coaching and I'm very much a part of them, even though I'm not physically there. So I think that the arguments that they make are legitimate when it comes to concerns, for sure. And that's where you just have to be able to talk through what their underlying concern really is and make sure that they understand that, when you're talking about like a rural practice, one of their biggest concerns is they don't have enough applicants.
Right. Absolutely.
They're kind of in a small
very long time to hire someone. Yeah.
That's right. But they need someone who has, let's just say, a really good accounting background. They need someone who can really help them with their accounts and with their numbers, those types of things. They don't have that in their small town. Well, a remote team member is someone who's great. Our virtual assistants have a college education. A lot of them are nurses and dentists and accountants and bookkeepers. And they make more money in their country by being a remote team member in the United States than they do in their own country with their college education, their 4-year college education. And they are so thrilled to work for a company who values their education that they've obtained. So
thank you so much. That's awesome. I love that window into it. That's really cool. I was not aware that it had come to a place yet that you could have the computer monitor with. That's really, really neat. I'd be interested in seeing what that office looks like. Carla.
Shelley, if I may add, just piggyback on what Rebecca said, I think a lot, like I've seen a lot of people that outsource services or do fractional work, a lot of organizations that do that. And I think one of the major concerns from my experience is that sense of control.
Yep.
Instead of having somebody in-house that they feel like they have more control over, because whether they're a W-2 or however, right? Versus having somebody that, they're not present they feel like they might not be part of the team and so forth. So I think it has,
dental work is so hands-on that you automatically put it that you have to be there.
yeah. And I think a perfect example could be like a call center, they're remote. They're definitely not plug and play at all.
Yeah.
They might know the basics of what a call center is. They might know the software that you're selecting and so forth, but they don't know the intricacies of like your appointments, your patients. So all that it needs to be learned. But that doesn't mean that it doesn't work, right?
Yeah,
Once in play. So I've seen a lot of that. And I also seen, during the pandemic, there was a lot of remote that, people went remote. And then after that, we kept like stable, a lot of remote. But I think now it's shifting again to a lot of organizations wanting staff to be in-house and like in the office. So I think there's a lot of mixed, opinions on that.
For sure. For sure. And there probably always will be on those kinds of subjects, and it's going to work for some and it'll be different for others. We're going to swing over to Leah. And I really, really love this question. It's talking about billing patients for upgraded materials in network with insurance. And I think that that's a really cool one. We have not touched on it at all today. And I'm sure it's a question that many people have.
Yes. So I think the insurance panelist touched on it earlier, and they called it utilization of a non-descriptive code and making sure that you have proper follow-up and documentation. And I think the biggest piece of this, and again, it comes back to talking about verbiage, which is the patient education and buy-in in the office of our office is utilizing a certain standard of material that is not covered by your dental insurance company. So for example, I had this come up a couple of weeks ago. I got a call from a dentist who the patient wanted a gold crown on a posterior tooth. And she had the whole conversation with the patient. The patient was on board that it was essentially an extra $200 fee to do the gold, because that is coming directly out of the overhead costs that Carla's not directly back to the dentist, and how we have those conversations, or even having zirconia crown versus an Emax crown, all of those things, or we're doing bonding where we're closing the triangle gaps. Those are all things where we're using specific types of material. And those are all services that we can bill directly to the patient without sending over to insurance. I know someone brought up nitrous, but I usually always use that as an example. We don't bill insurance companies if we're doing whitening, or typically if we're doing nitrous, because most of them, it's not something that they cover. So it's the same with these non-descriptive codes. You can come up with a miscellaneous code in your office, have the discussion, and then just make sure that you have the documentation. I have explained the options to the patient. The patient understands that this is an elective aesthetic procedure and won't be billed to my insurance company. And I think that's a huge piece of it, is one, getting doctor and team comfortable having those conversations about value-added services with patients, and then just making sure that it's something added to the treatment plan. Some states do require that you have a whole separate sheet disclosing that, depending on what insurances you're on in network with. And I look at that specifically with offices. But my focus tends to be, what are the opportunities that we're missing? How can we help you grow your revenue with the things that we're already doing, and making sure that we're getting paid for the services that we're already providing, and that we're covering, as Carla's talking about, the overhead associated with that. So I think those are all really important things to make sure that we're getting compensated for.
I think too, you sort of brushed on something there as well that is very, very important. And you don't want a patient leaving saying, well, if I would have known, I could have had that. Right?
Yeah,
I mean,
sure.
Give options, right? Like, it doesn't even necessarily have to be pitched as a value add. It doesn't need to be pitched as, a financial resource. It's, if I could have a different type, what would it cost, right? And give me the option to make the choice. So you don't really have to feel like you're upselling. You can feel like you're alternatively giving an option, right?
Right.
Yeah,
Exactly.
absolutely. Yeah. I like that a lot. Now, Carla, let's talk about you would think that after saying it so many times today, it would just roll right off. But procurement and operations, how are they relating to each other?
Oh my gosh, I think Leah just said it. I mean, it's really,
it's also intertwined.
Yeah, I think it's really important to the way I see it, I always suggest when people come to me, and for consulting advice, I always try to say, not always you're going to find a candidate that has operational background, but I really suggest for when hiring somebody for procurement, you want to make sure that they have business and clinical background. And the clinical background does not mean that they came from being on share side. Clinical background could be somebody that has operational experience within a dental office. And the reason why is because, as Leah mentioned, when you're looking at buying supplies, like for example, I always use the SDF, which is not low price supply. It's actually expensive. And but then you also want to make sure that it's integrated in that fee that when you're applying that to the patient, right? Like dental implants is just yet another one. Like dental implants are, a really big one. If you're paying really high fee for that implant, a high cost, then you're looking at your fee and you're saying, am I covering everything? Am I covering the implant cost? Am I covering the additional materials that go into the procedure? Am I covering, the labor costs? So it's really important to understand the services that the offices provide, and then how you're gonna, how much you want to pay for that. So I think, like if you're offering fluoride, do you want to make sure that you're offering one brand of fluoride, or are you all, are we let's say a group practice that has 10 practices and then all 10 practices use a different fluoride, right? So from a procurement perspective, that doesn't give you a lot because you're not getting in a consolidated way the leverage that you need to negotiate price. But if all 10 practices agree on the same fluoride, then you can actually go back to the supplier and say, hey, we are committed to your product, which is a high quality product. It could be at a higher cost, but once you put into perspective like the volume that you're going to get by using only one instead of 10, then you're able to leverage better pricing and better negotiations to actually get it at a cost that you can absorb and not necessarily affect your fees and what you're getting back from. So I think definitely understanding operations, services provided. When you add new doctors, sometimes people forget that a lot of times when you hire a doctor, they want to have some of their own instruments. They want to have, if you're adding a service, let's say you weren't offering endo and now you're going to offer endo, you need equipment for endo, you need supplies for endo. And a lot of people don't think that from a procurement perspective. And then what they're doing is they're scrambling because they have patients on the schedule, but then they didn't think about that they needed to have everything to provide those services, right?
And what if your x-ray isn't proper for endo? Now you've got a real problem because that's going to take months.
Yes. And then, for example, if you wanted, you were a practice that only did, your regular general services, you had a panoramic machine, but now you're bringing an associate, a doctor that is going to place implants. So now you want to have, a CT machine. And so you have to consider all those things when you're planning a budget when it comes to procurement. And one last note I'm going to say, how at the end of the year, let's say Q4, you're sitting down with your CFO, your CEO, everybody, and then you're all planning the budget for next year. So you want to say, okay, I want this practice to grow by X percentage or whatever. Yes, if you're growing production, that means that you're growing supplies costs, right? So you want to make sure they go in tangent, right? So you want to make sure that when you're preparing for that, you're also thinking about, well, we're growing 10%. So what's the supply growth is going to be for my expense? You're not going to keep paying 2 million. You're probably going to drive 3 million, 4 million, right, in supplies, but you're also increasing your production. So anyway, just my tip.
So you talked, and I want to go back to something. What about the individual office? You talked about budgeting and going through and planning your capital expenditures. We all know that there's a lot of people listening right now that aren't doing that aren't sitting down at the top of Q4 and figuring out what they're going to do in Q1 for the next year. I don't have a CFO. I don't have a COO. I'm a small office. I've got an office manager and a front desk that they're taking care of things. Who am I bringing into the room with me, and when should I be doing that, Carla?
Yeah, I think everybody has a different time frame when they sit down for budget. I would say, a lot of people do it. You should do it throughout the year, right? But when you're actually sitting down and planning for the following year, I would say a lot of people do it in Q3, Q4, beginning of Q4. Yep. And I would say, bringing whoever is in charge of operations, and if that's the practice manager, then I will bring that person in. I would also bring depending on where you're at in your budget, I will bring somebody from RCM, review cycle management. If it's the same practice manager, then that's fine.
Yep.
And then I would definitely either bring the information in or the person of who does the ordering at the practice level.
Yeah.
So sometimes it's a dental assistant or a dental hygienist or the practice manager. It depends, right, on the setup of your team. So I will definitely have all those people in, and then whoever, let's say if you're an individual practice that wants to grow, then I would definitely, if you're the CEO or you're the practice owner, then your perspective and growth goals definitely have to be in the room as well. So yeah, and then budget when it comes to procurement. It's, I would put monthly budgets aside. There's
And
about
track it and track it
every month.
You're sitting down the first week of the next month going over what happened.
Yeah. And I would say if you don't have if you don't have the setup of a team or a larger organization, then a lot of historical data. If you want to look back, when you're looking at supplies, you want to look back 12 months. How much did I spend, the last 12 months?
Yeah.
And then how much am I thinking about spending if I do growth? And so I think and one thing that I want to say last bit is the last 3 years has been a really big increase on procurement platforms.
Yeah.
And that's something that I always suggest, because like any other technology tool out there, procurement platforms just help you consolidate all those vendors into one. Like if you were buying from Amazon, same concept. And so
and to clarify, I believe that Carla's talking about specific software as platform. That's what we're talking about. Yeah.
Yes, correct. A specific technology focus on just consolidating the vendors and the supplies that you buy for your practice. So instead of having to call, your distributors independently or email or text, you put everybody and all the costs, all the supplies, everything in that technology. And like I said, it functions similar to what an Amazon does or, and then you can do it all in one. So it just increases that operational efficiency.
That's awesome. Thank you. Those are great tips. This has been a really, really great day for tips. Rebecca, as we start to get down to our last 10 minutes here, and if anybody has any questions, pop them in and I will try to work them in to our session. Rebecca, as we start to wrap up, how do you see the role of virtual assistants changing and evolving over the next few years? We're in, I think, a very, very big period of change for a lot of things like this. Where are you seeing it going?
Yeah, I think we are in a big period of change. We've got a lot of things coming in with AI and, things like that are coming into our practices that are helping us be more efficient, more putting in processes in our practices that make us more efficient. And I think that virtual assistants are doing this for us as well. I don't think that they're meant to replace anyone in our practice at all. I think they're just there to help us be more efficient and helping us to take off, I think, the stress and the burden that we place on our team members at times. And I can see, at least with the conversations that I have on a daily basis with practices, with dentists and with office managers, I think that this is something that they see as a way to assist them in being more efficient and allowing them to have the time that they need to offer the patient care that they really want to give to their patients when they're in the practice. And for them, that is what's most important, that they're trying to get back to by utilizing some of these resources that they have, whether it's, an AI platform that answers their phones for them and can answer some of those questions, or it is utilizing a virtual assistant to help them with some of their revenue cycle management, their phones, working and getting their patients back into the practice because they just don't have that time or ability. I think a lot of practices are seeing this as a way to build their production, build their practices, and allowing their in-office team to focus on that patient and their experience in the practice by allowing them the time and effort that they need, by not burning them out and allowing them to have a little bit better of a work-life balance, which I think we're all looking for.
If I am a ultra busy dentist, losing my mind, growing like crazy, I'm trying to disperse as much as I can, keep myself super efficient. Is it realistic, practical, and affordable to have a personal assistant? That's a real question that I have. Is it?
Actually, yes. A lot of dentists reach out looking for their own
help with my meetings,
executive assistant.
help set up with Carla and procurement. I need to talk to Leah about how we're doing our insurance. Take care of that for me, please, Barbara.
Yes, a lot of them, probably a third of the phone calls and meetings that I have are with dentists wondering if they can have their own executive assistant.
It makes a lot of sense, right? It takes those things off your plate if somebody else can take care of it for you. Maybe we get some family time back, or whatever the important, passionate thing that you have is, maybe we actually get that back.
Yeah, I actually had a phone call yesterday with a dentist who was for this exact same reason. She felt she was doing everything after hours. And a lot of times it was payroll. It was, taking some of those emergency phone calls on the weekends and wanted to know the exact same thing. And we got her.
You just end up chasing yourself. You never catch up with yourself. You never have that breather. You never get to sit down. And that's when you start missing looking at the budget from last month. And that's when you start missing not going into my practice management and updating those codes, or making sure that somebody did. If you can get somebody to help take that weight away, I think it's a very big deal.
Yeah, it really is offering people, everyone on the team, including the dentist, the owner, the time that they need to get back a little bit of their sanity and their work-life balance and their family.
Yeah. To recharge. Yeah.
Owning a practice isn't an easy thing, right? In school, dentists are like, oh yeah, this is going to be great. I'll graduate, I'll associate, then I'll open a practice. It changes really, really quickly. Leah, I would like to talk about anything that you think that is integral that a practice takes up doing this year, other than trying to offload things that they shouldn't be doing.
Great question. I think piggybacking a little bit off of what Rebecca's been talking about, which I agree, I think is where dentistry is headed and some of the big change that's coming. And that's really having the people that are in our practice being patient forward. So some of these other items that, like she was speaking about, insurance verifications, utilizing technology and systems for those, outsourcing the insurance verifications or the insurance posting, everything that can be done, outside of the office or that can support that admin team so that they can spend time with patients that are standing in front of them, taking those phone calls and making sure that they have time to connect, use their verbal skills, to really hear what the patient is looking for, and making sure that we're not missing opportunities that we're spending a lot of extra dollars marketing towards. I think another really important thing that we talked about today is making sure that we're billing all the things that we could be, taking advantage of all the opportunities for production and revenue. One thing that I was thinking about that we didn't touch on today that I'm a big proponent of that does help doctors get paid for crowns. And I've seen a lot of this recently. I've got a lot of feedback from offices, and you may have heard this as well, that more crowns are getting denied. And so I'm even recommending when they're in the middle of prepping that they're taking a photo and an x-ray at that point and just letting the patient know, hey, we're doing this to help make sure that we get any dental benefit coverage that we can get for you. And so I think just really showing patients that, yes, we're going over and above to utilize their dental benefits, but also there's so many other things that we could be offering you that is a benefit to the patient and improves the level of care that we're giving them, but also is a reflection of the customer service and how we take care of patients in our office. So I think that's huge. I always use the admin tip of patients first, then the schedule, and then everything else is, and we know it's a lot, as Rebecca's been talking about.
Patient in front of you, you'd like it an awful lot if they came back. Yeah.
Yes.
Thank you so much, Leah.
Absolutely.
I have the same question for you. What is the big thing that you're going to tell people to take away for 2025?
Yeah, I think, well, first of all, I think the concept of value-based procurement, which is something that is new, it's more on in Europe and so forth, and it's actually coming now to the States. It's really important because you want to make sure, like Leah mentioned, you want to make sure that you have quality materials because the patient always comes first, and is making sure that you have good quality material, but at the same time being able to leverage and negotiate good pricing for those. So value-based procurement is a really big one. A second one would be, whether you have a procurement person or not, is really staying in tune with the progress of the industry. There's been a lot of progress in the last couple of years when it comes to technology, to products, to services.
And patients know it. They know it, right? They expect you to know it. Yeah.
You have like AI in X-rays. You have, you have companies that, there's a company called Patient Prism, which they listen to your conversation, and then, they give you points in how you can convert those telephones into actual treatment plans. You have, insurance verification and claim processing. There's so much new advantages in the industry that I think having somebody that really focuses on that is really important. And then the last bit would be, you may not have time to look at the data like daily or even monthly, but really at least quarterly. You want to make sure that you look at your data, and you want to make sure that you really know who those suppliers are that you're working with, because you want to hone in those relationships, because those are key.
That's a really good place to also look at engaging outside help, to have like a really good session with somebody to sit down and say, okay, what are the numbers I should look at daily, weekly, monthly, quarterly? Yeah. And there is a set of numbers that you should look at every day. If they're on track, fantastic. And looking at them and understanding them, it protects you from embezzlement. It protects you from all kinds of things, right? So you want to be doing that and diving into it and paying real attention to it. It's hard.
Well, you mentioned P&Ls. I'm a believer of practice managers understanding P&Ls.
100%. Exactly.
I mean, if not, to me, they're flying blind.
Partner, right?
If you're expecting them to run the practice and they don't understand a P&L, then they're flying blind.
You're doing a disservice to yourself. Absolutely. I would love to know, Rebecca, if we get in touch with you today, what can we expect? And I believe that the team is going to share your contact information in the chat. And we want to know more about how we get ourselves a virtual assistant. How do we get in contact with you, and what can we expect when we call?
Absolutely. Thank you. Appreciate that. Reaching out to me via email is probably the best. And we can set up a complimentary discovery call. We can talk through what some of your pain points are in the practice. And I can help you discover some ways that we can help your practice be more efficient, come up with some processes. And one of the great things I love about the company I work with is that we basically create the SOP for the virtual assistant. So they're not going to come in blind.
Yeah.
And they'll be effective on day one for you. So
that might be the first SOP the office has.
It's very true. We will help you create the other ones if you'd like.
Probably often is. Yeah. And Leah, how do we get in touch with you? And I think that the team is going to share. And what happens when we call you?
Absolutely. Email is always a great point of contact to begin with, or my phone number, which is there as well. To get started, usually what I do is schedule a complimentary phone consultation. We talk about your practice, where maybe some of the opportunities are, how I could support those, what are your personal professional goals, and then how do I work backwards with you to help accomplish some of those goals. And then if it makes sense and we decide to move to the next level, I typically do an in-person office visit, practice analysis, and I'm able to give a lot more detail with regards to what other opportunities there are in their office for growth that align with the goals and things that the doctor or team has shared that they want to accomplish in their office.
And you work you all work right across the country. Is that correct?
Mostly West Coast for me.
Mostly West? Okay, that's
West Coast. Right now I do a lot in Washington, Colorado, and Utah, and Arizona. Yeah.
Wonderful. Thank you for that. Thank you for that. And Carla, how am I getting in touch with you, and what does it look like?
Yeah, I mean, I would say like everybody else, email, I think it will be the best. Also LinkedIn, I'm very active on LinkedIn. So I actually read my messages.
Everybody go friend Carla.
Right. And what I usually do is what I call like, if somebody approaches me for consulting, I do like a discovery call, which is basically just learning more about their organization, what their needs are. And sometimes they align with what I offer, and sometimes they don't. And if they don't, then I try always to kind of suggest which routes they should go, or even connect them to people in the industry that I know that might be able to be a better fit. So yeah, I mean, and I do procurements and operations more on the business side. of growth. Like Leah mentioned, an assessment is when it comes to your supplies, and then I do what I call a statement of work of what I suggest will be the next step.
Amazing. Thank you. I have to thank you ladies very, very much. I hope to be able to see everybody again in the near future, and have a great spring, because it's spring. Take care, everybody. And we're going to welcome Ben back for our wrap up. I hope he's there, Ben. And in the meantime, Ben, I'm going to put in a spot about Equa, because I have to. And the reason that I do so much, I'm going to tell you guys the reason that I do, is because without Ben and without Naren, none of this exists. We don't have any of this. They are not only the major sponsors, they're the founders, they're the sponsors. And we want to help you. We want to have a good look at everything that you're doing, and we want to bring in patients, and we want to do it without having patient acquisition costs that you're paying forever and ever and ever. It makes no sense to us. So let's make it a little bit better in your office and help you get off PPOs. Speaking of getting off PPOs, hi, Ben.
Hey there, Shelley. Well, that was amazing. Carla, Leah, and Rebecca, thank you so much for that amazing content. I hope you get some love from the listeners, including those that we're going to e-blast this to, so that all of the Insurance Untangled family can hear about today's amazing content. Shelley, the last question that we have here as far as housekeeping is, how do the attendees obtain the CE credit?
The CE credit, I believe that they have to analyze and make sure, because the rules are you have to be there at the beginning and end. Once they have that determined, they should come out fairly shortly after that. So you should automatically get them. I've been told it's about a week or so. Give them a little bit of grace. There's a little bit of time. So give them till the end of next week, maybe the very beginning of the week after, and you'll get it automatically.
That is awesome.
Oh, you went mute, Ben?
An amazing.
There you are.
So sorry. Again,
okay,
tornado.
Okay. We all understand.
No cell
I'm surprised
towers.
you're here today, sir. So.
Well, it's been such an amazing day of continuing education. I'm sorry. Somebody keeps calling on my cell phone. That's how I'm connected through the audio. Can you still hear me?
Yeah. Don't worry about it at all. Don't worry about it at all.
I will wrap up. I'm going to be simple. Thank you, everybody, for joining us. We will have the next webinar, Insurance Untangled quarterly webinar in June, and we'll make an announcement about that through email as well as on the podcast as well. But I want to thank all of our guests for joining us. Without you, we would not have such an amazing series of webinars. So thank you to all our wonderful guests and panelists for today. Until we meet next time, I just want to wish everybody, like we always say on the podcast, we wish all of you the very best of success. Take care, everybody.
Thank you, everybody. Have a great day.